Infection control. Appendix PP, Regulation Section 483.80, tags F880 through F883. Begin reading. Tag F880. Section 483.80, Infection control. The facility must establish and maintain an infection prevention and control program designed to provide a safe, sanitary, and comfortable environment, and to help prevent the development and transmission of communicable diseases and infections. Section 483.80, A Infection Prevention and Control Program. The facility must establish an infection prevention and control program, IPC, that must include, at minimum, the following elements. Section 483.80A1, a system for preventing, identifying, reporting, investigating, and controlling infections and communicable diseases for all residents, staff, volunteers, visitors, and other individuals providing services under a contractual arrangement. Based upon the facility assessment conducted according to Section 483.71 and following accepted national standards. Section 483.80A2, written standards, policies, and procedures for the program, which must include, but are not limited to, a system of surveillance designed to identify possible communicable diseases or infections before they can spread to other persons in the facility. Roman 2, when and to whom possible incidents of communicable disease or infections should be reported. Roman 3, standard and transmission-based precautions to be followed to prevent spread of infections. Roman 4, when and how isolation should be used for a resident, including but not limited to a. the type and duration of the isolation, depending upon the infectious agent or organism involved, and b. a requirement that the isolation should be the least restrictive possible for the resident under the circumstances. v. the circumstances under which the facility must prohibit employees with a communicable disease or infected skin lesions from direct contact with residents or their food if direct contact will transmit the disease, and Roman 6, the hand hygiene procedures to be followed by staff involved in direct resident contact. Section 483.80A4, a system for recording incidents identified under the facility's IPC and the corrective actions taken by the facility. Section 483.80E, linens. Personnel must handle, store, process, and transport linens so as to prevent the spread of infection. Section 483.80F, annual review. The facility will conduct an annual review of its IPC and update their program as necessary. Intent Section 483.80A1, A2, A4, E, and F. The intent of this regulation is to ensure that the facility develops and implements an ongoing infection prevention and control program, IPC, to prevent, recognize, and control the onset and spread of infection to the extent possible, and reviews and updates the IPC annually and as necessary. This would include revision of the IPC as national standards change. Establishes facility-wide systems for the prevention, identification, reporting, investigation, and control of infections and communicable diseases of residents, staff, and visitors. It must include an ongoing system of surveillance designed to identify possible communicable diseases and infections before they can spread to other persons in the facility, and procedures for reporting possible incidents of communicable disease or infections. Note, for purposes of this guidance, staff includes all facility staff, direct and indirect care functions, contracted staff, consultants, volunteers, others who provide care and services to residents on behalf of the facility, and students in the facility's nurse aid training programs or from affiliated academic institutions. Develops and implements written policies and procedures for infection control that are minimum. O define standard precautions to prevent the spread of infection and explain their application during resident care activities. O define transmission-based precautions and explain how and when they should be utilized, including but not limited to the type and duration of precautions for particular infections or organisms involved, and that the precautions should be the least restrictive possible for the resident given the circumstances and the resident's ability to follow the precautions. O prohibit staff with a communicable disease or infected skin lesions from direct contact with residents or their food if direct contact will transmit the disease. And O require staff to follow hand hygiene practices consistent with accepted standards of practice. Requires staff to handle, store, process, and transport all linens and laundry in accordance with accepted national standards in order to produce hygienically clean laundry and prevent the spread of infection to the extent possible. Definitions. Airborne precautions refer to actions taken to prevent or minimize the transmission of infectious agents/organisms that remain infectious over long distances when suspended in the air. These infectious particles can remain suspended in the air for prolonged periods of time and can be carried on normal air currents in a room or beyond to adjacent spaces or areas receiving exhaust air. 1. Alcohol-based hand rub ABHR refers to a 60 to 95% ethanol or isopropyl alcohol-containing preparation base designed for application to the hands to reduce the number of viable microorganisms. C. Difficile infection CDI refers to an infection from a bacterium that causes colitis, an inflammation of the colon causing diarrhea. Cleaning refers to removal of visible soil, e.g., organic and inorganic material, from objects and surfaces, and is normally accomplished manually or mechanically using water with detergents or enzymatic products. Cohorting refers to the practice of grouping residents infected or colonized with the same infectious agent together to confine their care to one area and prevent contact with susceptible residents. Cohorting residents. 2. During outbreaks, healthcare staff may be assigned to a specific cohort of residents. 2. Further limit opportunities for transmission. Cohorting staff. The term cohort or cohorting is standardized language used in the practice of infection prevention and control. The use of this terminology is not intended to offend residents or staff. Colonization refers to the presence of microorganisms on or within body sites without detectable host immune response, cellular damage, or clinical expression. 3. Communicable disease, also known as AKA contagious disease, refers to an infection transmissible, e.g., from person to person by direct contact with an affected individual or the individual's body fluids, or by indirect means, e.g., contaminated object. Community-acquired infections, aka present on admission, refer to infections that are present or incubating at the time of admission and which generally develop within 72 hours of admission. Contact precautions refer to measures that are intended to prevent transmission of infectious agents which are spread by direct or indirect contact with the resident or the resident's environment. 4. Contaminated laundry refers to laundry which has been soiled with blood/body fluids or other potentially infectious materials, or may contain sharps. Decontamination refers to the use of physical or chemical means to remove, inactivate, or destroy pathogenic organisms on a surface or item to the point where they are no longer capable of transmitting infectious particles, and the surface or item is rendered safe for handling, use, or disposal. Disinfectant refers to usually a chemical agent, but sometimes a physical agent that destroys disease-causing pathogens or other harmful microorganisms, but might not kill bacterial spores. It refers to substances applied to inanimate objects. 5. Disinfection refers to thermal or chemical destruction of pathogenic and other types of microorganisms. Disinfection is less lethal than sterilization because it destroys most recognized pathogenic microorganisms, but not necessarily all microbial forms, e.g., bacterial spores. 6. Droplet precautions refer to actions designed to reduce/prevent the transmission of pathogens spread through close respiratory or mucous membrane contact with respiratory secretions. Hand hygiene refers to a general term that applies to hand washing, antiseptic hand wash, and alcohol-based hand rub. 7. Hand washing refers to washing hands with soap and water. 8. Healthcare-associated infection high refers to an infection that residents acquire that is associated with a medical or surgical intervention, e.g., podiatry, wound care, debridement within a nursing home and was not present, incubating at the time of admission. Hygienically clean refers to being free of pathogens in sufficient numbers to cause human illness. 9. Infection refers to the establishment of an infective agent in or on a suitable host, producing clinical signs and symptoms, e.g., fever, redness, heat, purulent exudates, etc. Infection preventionist refers to the person designated by the facility to be responsible for the infection prevention and control program as specified in Section 483.80 F882. Legionellosis refers to two clinically and epidemiologically distinct illnesses. Legionnaire's disease, which is typically characterized by fever, myalgia, cough, and clinical or radiographic pneumonia, and Pontiac fever, a milder illness without pneumonia, e.g., fever and muscle aches. Legionellosis is caused by Legionella bacteria. Multidrug-resistant organisms, MDRO, refer to microorganisms, predominantly bacteria, that are resistant to one or more classes of antimicrobial agents, although the names of certain MDRO describe resistance to only one agent. These pathogens are frequently resistant to most available antimicrobial agents. Personal protective equipment, PPE, refers to protective items or garments worn to protect the body or clothing from hazards that can cause injury and to protect residents from cross-transmission. Standard precautions refer to the infection prevention practices that apply to all residents, regardless of suspected or confirmed diagnosis or presumed infection status. Standard precautions is based on the principle that all blood, body fluids, secretions, excretions except sweat, regardless of whether they contain visible blood, non-intact skin, and mucous membranes, may contain transmissible infectious agents. Furthermore, equipment or items in the resident's environment likely to have been contaminated with infectious body fluids must be handled in a manner to prevent transmission of infectious agents. Standard precautions include hand hygiene, proper selection and use of personal protective equipment, safe injection practices, respiratory hygiene/cough etiquette, environmental cleaning and disinfection, and reprocessing of reusable resident medical equipment. 10. 11. Transmission-based precautions, aka isolation precautions, refer to actions, precautions implemented in addition to standard precautions that are based upon the means of transmission, airborne, contact, and droplet in order to prevent or control infections. Note, although the regulatory language refers to isolation, the nomenclature widely accepted by the healthcare community and used in this guidance will refer to transmission-based precautions instead of isolation, as these terms can be used interchangeably. Note, references to non-CMS sources are provided as a service and do not constitute or imply endorsement of these organizations or their programs by CMS or the U.S. Department of Health and Human Services. CMS is not responsible for the content of pages found at these sites. URL, addresses, and referenced documents were current as of the date of this publication. Guidelines change, and facilities are responsible for following the most current standards. Guidance, Section 483.80A1, A2, A4, E, and F. Infection Prevention and Control Program. Healthcare-associated infections, HI, can cause significant pain and discomfort for residents in nursing homes and can have significant adverse consequences. The facility must establish and maintain an IPC designed to provide a safe, sanitary, and comfortable environment and to help prevent the development and transmission of communicable diseases and infections. This program must include, at a minimum, a system for preventing, identifying, reporting, investigating, and controlling infections and communicable diseases for all residents, staff, and visitors. The IPC must follow accepted national standards and guidelines. We expect facilities to tailor the emphasis of their IPC for visitors and to work to prevent transmission of infection to the resident from the visitor using reasonable precautions and national standards. 12, for example, screening may be passive through the use of signs to alert family members and visitors with signs and symptoms of communicable diseases not to enter. More active screening may include the completion of a screening tool or questionnaire, which elicits information related to recent exposures or current symptoms. That information is reviewed by the facility staff, and the visitor is either permitted to visit or is excluded. 13. The infection prevention and control program must include, at a minimum, the following parts: a system for preventing, identifying, reporting, investigating, and controlling infections and communicable diseases that covers all residents, staff, contractors, consultants, volunteers, visitors, others who provide care and services to residents on behalf of the facility, and students in the facility's nurse aid training programs or from affiliated academic institutions. O is based on the individual facility assessment conducted under Section 483.71, and O follows accepted national standards. Written standards, policies, and procedures in accordance with Section 483.80A2. A system for recording incidents identified under the IPC and corrective actions taken by the facility, and an antibiotic stewardship program as pursuant to Section 483.80A3 for more information on ASB requirements. See F881. Facility assessment. Pursuant to Section 483.71 F838, the facility must conduct and document a facility-wide assessment to determine what resources are necessary to care for its residents competently during both day-to-day operations and emergencies. The facility must review and update that assessment as necessary and at least annually. The facility must also review and update this assessment whenever there is, or the facility plans for any change that would require a substantial modification to any part of this assessment. The facility assessment must address or include, among other things, a facility-based and community-based risk assessment utilizing an all-hazards approach. See Section 483.71 F838. For guidance on the facility assessment, the results of the facility assessment must be used in part to establish and update the IPC, its policies and or protocols to include a system for preventing, identifying, reporting, investigating, and controlling infections and communicable diseases for residents, staff, and visitors. Note: a community-based risk assessment should include review for risk of infections, e.g., multi-drug-resistant organisms / MDRO and communicable diseases such as tuberculosis and influenza. Appropriate resident tuberculosis screening should be performed based on state requirements. Note: while not required for compliance, a sample tool of an infection control risk assessment is available for adaptation. 14. Infection control policies and procedures. The facility must develop and implement written policies and procedures for the provision of infection prevention and control. The facility administration and medical director should ensure that current infection control standards of practice based on recognized guidelines and facility assessment are incorporated in the resident care policies and procedures. These IPC policies and procedures must include, at a minimum, the following: as necessary, and at least annually, review and revision of the IPC based upon the facility assessment according to 483.71, which includes any facility and community risk. An ongoing system of surveillance designed to identify possible communicable diseases or infections before they can spread to other persons in the facility. When and to whom possible incidents of communicable disease or infections should be reported within the facility. Which communicable diseases are reportable to local / state public health authorities. Define and explain standard precautions and their application during resident care activities. Define transmission-based precautions, i.e., contact precautions, droplet precautions, airborne precautions, and explain how and when they should be utilized as consistent with accepted national standards. The areas listed below are examples of standard and / or transmission-based precautions, 15 which are further described under their respective sections. Hand hygiene, HHEG, hand washing and / or ABHR, consistent with accepted standards of practice, such as the preferential use of ABHR instead of soap and water in most clinical situations, except when hands are visibly soiled. 16 e.g., blood, body fluids, or after caring for a resident with known or suspected C. difficile or norovirus infection during an outbreak, or if rates of C. difficile infection CDI are high. In these circumstances, soap and water should be used. 17. Note: according to the Centers for Disease Control and Prevention (CDC), strict adherence to glove use is the most effective means of preventing hand contamination with C. difficile spores, as these spores are not killed by ABHR and may be difficult to remove even with thorough hand washing. Additional information on appropriate hand hygiene practices may be found in CDC's Hand Hygiene in Healthcare Settings website at http://www.cdc.gov/handhygiene/providers/index.html. The selection and use of PPE, e.g., indications, donning / doffing procedures, and the clinical conditions for which specific PPE should be used, e.g., CDI, influenza. Addressing the provision of face masks for residents with new respiratory symptoms. Addressing resident room assignment, e.g., single / private rooms / cohorted as appropriate and / or available, based on a case-by-case analysis of the presence of risk factors for increased likelihood of transmission, e.g., uncontained drainage, stool incontinence 18. The process to manage a resident on transmission-based precautions when a single/private room is not available. Limiting the movement of a resident who is on transmission-based precautions to medically necessary purposes only 19. Respiratory hygiene/cough etiquette, implementing policies and procedures, would include providing resources and instructions for performing HH in or near lobby areas or entrances in accordance with accepted national standards. During times of increased prevalence of respiratory infections in the community, facilities should have face masks available and offer them to visitors and others entering the facility. In addition, the facility should post signs with instructions on visitation restrictions for those with symptoms of respiratory infection or other communicable diseases 20 and environmental cleaning and disinfection. Routine cleaning and disinfection of frequently touched or visibly soiled surfaces in common areas, resident rooms, and at the time of discharge. And note, privacy curtains should be changed when visibly dirty and should be laundered or disinfected with an environmental protection agency EPA-registered disinfectant per the curtain and disinfectant manufacturer's instructions. Routine cleaning and disinfection of resident care equipment, including equipment shared among residents, e.g., blood pressure cuffs, rehabilitation therapy equipment, blood glucose meters, etc. Written occupational health policies that should address reporting of staff illnesses and following work restrictions per nationally recognized standards and guidelines 21-22. Prohibiting contact with residents or their food when staff have potentially communicable diseases or infected skin lesions. Assessing risks for tuberculosis TB based on exposure or cases of TB in the facility, then screen staff for TB to the extent permitted under applicable federal guidelines 23 and state law. Monitoring and evaluating for clusters or outbreaks of illness among staff, and implementing an exposure control plan in order to address potential hazards posed by blood and body fluids, e.g., from dialysis, glucose monitoring, or any other point-of-care testing. Facilities must ensure staff follow the IPP standards, policies, and procedures. Knowledge and skills pertaining to the IPP standards, policies, and procedures are needed by all staff in order to follow proper infection control practices, e.g., hand hygiene and appropriate use of PPE, while other needs are specific to particular roles, responsibilities, and situations, e.g., injection safety and point of care testing, and residents and their representatives should receive education on the facility's IPP as it relates to them, e.g., hand hygiene, cough etiquette, and to the degree possible/consistent with the resident's capacity. For example, residents should be advised of the IPP standards, policies, and procedures regarding hand hygiene before eating and after using the restroom. Surveillance. The facility must establish a system for surveillance based upon national standards of practice and the facility assessment, including the resident population and the services and care provided. The facility must establish routine, ongoing, and systematic collection, analysis, interpretation, and dissemination of surveillance data to identify infections, i.e., HAI and community-acquired, infection risks, communicable disease, outbreaks, and to maintain or improve resident health status. As part of the system of surveillance, the facility should determine how it will track the extent to which staff are following the facility's IPP policies and procedures, and facilities should address any areas that need corrective action. The facility's surveillance system must include a data collection tool and the use of nationally recognized surveillance criteria, such as but not limited to the CDC's National Healthcare Safety Network, NHSN long-term care criteria to define infections or updated Majir criteria. Point 24. Furthermore, the facility must know when and to whom to report communicable diseases, healthcare-associated infections as appropriate, and potential outbreaks, e.g., list of communicable diseases which are reportable to local/state public health authorities. The facility must document follow-up activity in response to important surveillance findings, e.g., outbreaks. In addition, the facility must establish and implement a system, including who to notify, e.g., infection preventionist, for early detection and management of a potentially infectious, symptomatic resident at the time of admission. This includes the identification and use of appropriate transmission-based precautions. Point 25. This is important to incorporate into the resident's baseline care plan that must be developed within 48 hours of admission and include the minimum healthcare information necessary to properly care for a resident, including physician orders, e.g., medication orders. See Section 483.21, Comprehensive Person-Centered Care Planning for further information. Furthermore, the facility must have a process for communicating information at the time of transfer, e.g., CDC, state, or other standardized interfacility infection transfer form. When a resident has an infection or is colonized. Point 26. When a resident is transferred, the information provided to the receiving provider must include special instructions or precautions, e.g., transmission-based precautions, if applicable, for ongoing care, and other necessary information, including a discharge summary if discharged. When a resident is discharged, the discharge summary must include the resident's disease, diagnosis and health conditions, course of illness/treatment or therapy, medications, and pertinent lab, radiology, consultation results, and instructions or precautions for ongoing care. See Section 483.21c2, Discharge Summary F881, and Section 483.15c2 Roman 3, Transfer and Discharge F822, for further information on these requirements. Additionally, as part of the overall IP for surveillance, the facility shall establish process and outcome surveillance. Process surveillance. Process surveillance is the review of practices by staff directly related to resident care. Point 27. The purpose is to identify whether staff implement and comply with the facility's IP policies and procedures. Some areas that facilities may want to consider for process surveillance are the following: hand hygiene, appropriate use of personal protective equipment, e.g., gowns, gloves, face mask, injection safety, point of care testing, e.g., during assisted blood glucose monitoring, implementation of infection control practices for resident care, such as but not limited to urinary catheter care, wound care, injection/Roman 4 care, fecal/urinary incontinence care, skin care, respiratory care, dialysis care, and other invasive treatments. Managing a bloodborne pathogen exposure. Note, this may not lend itself to monitoring and feedback. Cleaning and disinfection products and procedures for environmental surfaces and equipment, e.g., objective methods for evaluation may include direct practice, observation, fluorescent markers, adenosine triphosphate at bioluminescence, a method for quantifying the concentration of environmental microorganisms, or swab cultures used primarily for outbreak investigation. 28. Appropriate use of transmission-based precautions, and handling, storing, processing, and transporting linens so as to prevent the spread of infection. Outcome surveillance. Another component of a system of identification is outcome surveillance. For example, this addresses the criteria that staff would use to identify and report evidence of a suspected or confirmed HAI or communicable disease. This process consists of collecting/documenting data on individual resident cases and comparing the collected data to standard written definitions, criteria of infections. Note, additional information related to examples of nationally accepted surveillance. Definitions may be found at the CDC/SHA position statement. Surveillance. Definitions of infections in long-term care facilities, revisiting the Majir criteria 29. Or NHSN at https://www.cdc.gov/NHSN/. The following are some sources of data that can be utilized in outcome surveillance for infections and antibiotic use and susceptibility. Monitoring a resident test with fever or other signs or symptoms suspicious for infection. Laboratory cultures or other diagnostic test results consistent with potential infections to detect clusters, trends, or susceptibility patterns. Antibiotic orders. Medication, regimen review reports. Documentation from the clinical record of residents with suspicion of an infection, such as physician orders/progress notes and or transfer/discharge summaries for new or readmitted residents for infections. 30. System of surveillance, data analysis, documentation, and reporting. The facility's policies and procedures for a system of surveillance must include data to properly identify possible communicable diseases or infections before they spread. Therefore, the policies and procedures would include identifying data to be collected, including how often and the type of data to be documented, including the infection site, i.e., type of infection, pathogen if available, signs and symptoms, and resident location, including summary and analysis of the number of residents and staff, if applicable, who developed infections. Observations of staff, including the identification of ineffective practices, e.g., not practicing hand hygiene and or using PPE when indicated, as well as practices that do not follow the facility's IPC policies and procedures, if any, and the identification of unusual or unexpected outcomes, e.g. foodborne outbreak, infection trends and patterns. How the data will be used and shared with appropriate individuals, e.g., staff, medical director, director of nursing, quality assessment and assurance, committee QAA, when applicable, to ensure that staff minimize spread of the infection or disease, e.g., require revision of staff education and competency. Assessment. The facility must identify how reports will be provided to staff and or prescribing practitioners in order to revise interventions, approaches, and or reevaluate medical interventions related to the infection rates and outcomes. Recognizing, containing, and reporting communicable disease outbreaks. The facility must know how to recognize and contain infectious disease outbreaks. An outbreak is the occurrence of more cases of disease than expected in a given area, or among a specific group of people over a particular period of time. 31. If a condition is rare or has serious health implications, an outbreak may involve only one case, while a single case of a rare infectious condition or one that has serious health implications may or may not constitute an outbreak. Facilities should not wait for the definition of an outbreak to act. For example, one case of laboratory confirmed influenza in a resident should alert the facility to begin an outbreak investigation. If an outbreak is identified, the facility must take the appropriate steps to diagnose and manage cases, implement appropriate precautions, and prevent further transmission of the disease, as well as documentation of follow-up activity and response, and comply with state and local public health authority requirements for identification, reporting, and containing communicable diseases and outbreaks. Note, some states have specific regulations regarding responding to and reporting outbreaks that must be included in the IPP. Note, if there are concerns that actions taken by the facility are not addressing public health authority instructions to contain and remedy the outbreak, the SA must notify the appropriate local/state public health authority if surveyors cite this tag. For an outbreak, utilize the guidelines in Appendix Q to determine if immediate jeopardy exists. Water management. The bacterium Legionella can cause a serious type of pneumonia called Legionnaires' disease in persons at risk, such as those who are at least 50 years old, smokers, or with underlying medical conditions, such as chronic lung disease or immunosuppression. Legionella can grow in parts of building water systems that are continually wet, e.g. pipes, faucets, water storage tanks, decorative fountains, and certain devices can spread contaminated water droplets via aerosolization. Legionellosis outbreaks are generally linked to locations where water is held or accumulates and pathogens can reproduce, including those found in long-term care facilities. Transmission from these water systems to humans occurs when the water is aerosolized, i.e., converted into a spray/mist in the air. Legionella is less commonly spread by aspiration of drinking water or ice. Facilities must be able to demonstrate its measures to minimize the risk of Legionella and other opportunistic pathogens in building water systems, such as by having a documented water management program. Water management must be based on nationally accepted standards, e.g., ASHRAE, formerly the American Society of Heating, Refrigerating, and Air Conditioning Engineers, CDC, U.S., Environmental Protection Agency, or EPA, and include an assessment to identify where Legionella and other opportunistic waterborne pathogens, e.g., Pseudomonas, a Cyanobacter, could grow and spread, and measures to prevent the growth of opportunistic waterborne pathogens, also known as control measures, and how to monitor them. Examples of an assessment include a description of the building water systems using text and flow diagrams for identification. Additionally, control measures may include visible inspections, use of disinfectant, and temperature that may require mixing valves to prevent scalding. Monitoring such controls include testing protocols for control measures, acceptable ranges, and documenting the results of testing. Water management should also include established ways to intervene when control limits are not met. An industry standard calling for the development and implementation of water management programs in large or complex building water systems to reduce the risk of Legionellosis was published by ASHRAE. The CDC and its partners developed a toolkit to facilitate implementation of this ASHRAE standard. Resources are available to develop and implement a water management program, such as the ASHRAE Standard 188 Legionellosis, Risk Management for Building Water Systems, https://www.ashrae.org. The CDC Toolkit to facilitate implementation of the ASHRAE standard, titled Developing a Water Management Program to Reduce Legionella Growth and Spread in Buildings, a Practical Guide to Implementing Industry Standards. https://www.cdc.gov/legionella/wmp/toolkit/index.html, and the EPA Technologies for Legionella Control in Premise Plumbing Systems. Scientific literature review is available at https://www.epagov/groundwater. and drinking water / technologies Legionella control premise plumbing systems. At this time, CMS does not require water cultures for Legionella or other opportunistic waterborne pathogens as part of routine program validation, although there may be instances when it is needed, e.g., a case of healthcare-associated legionellosis or a potential outbreak of legionellosis in the facility. The facility should contact the local / state public health authority if there is a case of healthcare-associated legionellosis or an outbreak of an opportunistic waterborne pathogen causing disease. The facility must follow public health authority recommendations, which may include, but is not limited to, remediating the pathogen reservoir and adjusting control measures as necessary. The SA should work with local / state public health authorities, if possible, to determine if the water management program was inadequate to prevent the growth of Legionella or other opportunistic waterborne pathogens, and whether the facility implemented adequate prevention and control measures once the issue was identified. Prevention and control of transmission of infection. Infectious organisms, e.g., bacteria, viruses, or parasites may be transmitted by direct contact, e.g., skin-to-skin, or indirect contact, e.g., inanimate objects. Healthcare staff and resident care equipment often move from resident to resident and therefore may serve as a vehicle for transferring infectious organisms. Direct contact transmission person to person occurs when microorganisms such as methicillin-resistant Staphylococcus aureus, MRSA, vancomycin-resistant Enterococci, VRE, carbapenem-resistant Enterobacteria C. influenza, or mites from a scabies-infected resident are transferred from an infected or colonized person to another person. In nursing homes, resident-to-resident direct contact transmission may occur in common areas of the facility such as the recreation room, rehabilitation area, and / or dining room. Indirect contact transmission involves the transfer of an infectious agent through a contaminated, inanimate object or person. The following are examples of opportunities for indirect contact transmission. Clothing, uniforms, laboratory coats, or isolation gowns used as PPE may become contaminated with potential pathogens after care of a resident colonized or infected with an infectious agent, e.g., MRSA, VRE, and C. difficile, and contamination of high-touch environmental surfaces, e.g., bedside table, bed, rails, toilets, sinks, and handrails, contributes to transmission of pathogens, including C. difficile and norovirus. Certain pathogens may contaminate and survive on equipment and environmental surfaces for long periods of time. Examples include, but are not limited to, C. difficile spores can live on inanimate surfaces for up to 5 months, 32. The hepatitis B virus can last up to a week on inanimate surfaces, 33, and the influenza virus can survive on fomites, e.g., any inanimate object or substance capable of carrying infectious organisms and transferring them from one individual to another for up to 8 hours. 34. Mechanisms to prevent and control transmission of infectious organisms through direct and indirect contact include standard and transmission-based precautions and are described in their subsequent sections. Standard precautions. Standard precautions represent the infection prevention measures that apply to all resident care, regardless of suspected or confirmed infection status of the resident, in any setting where healthcare is being delivered. These evidence-based practices are designed to protect healthcare staff and residents by preventing the spread of infections among residents, staff, and visitors, and ensuring staff do not carry infectious pathogens on their hands or via equipment during resident care. as mentioned above in the definitions. Section: Standard precautions include hand hygiene, selection and use of PPE, e.g. gloves, gowns, face masks, respirators, eye protection, respiratory hygiene, and cough. Etiquette, safe injection practices, environmental cleaning and disinfection, and reprocessing of reusable resident medical equipment. 35-36. In order to perform hand hygiene appropriately, soap, water, abhor, and a sink should be readily accessible in appropriate locations including, but not limited to, resident care areas and food and medication preparation areas. Staff involved in direct resident contact must perform hand hygiene even if gloves are used. Hand hygiene is performed 37. Before and after contact with the resident. Before performing an aseptic task. After contact with blood, body fluids, visibly contaminated surfaces, or after contact with objects in the resident's room. After removing personal protective equipment, e.g., gloves, gown, face mask. After using the restroom, and before meals. If residents need assistance with hand hygiene, staff should assist with washing hands. After toileting, before meals, and use of abhor or soap and water at other times when indicated. Certain PPE may be required when working in the facility, such as use of face masks or eye protection during a respiratory virus pandemic. Additionally, the use of PPE during resident care is determined by the nature of staff interaction and the extent of anticipated blood, body fluid, or pathogen exposure to include contamination of environmental surfaces. Furthermore, appropriate use of PPE includes, but is not limited to, the following: gloves worn before and removed after contact with blood or body fluid, mucus, membranes, or non-intact skin. Gloves changed, and hand hygiene performed before moving from a contaminated body site to a clean body site during resident care. Gown worn for direct resident contact if the resident has uncontained secretions or excretions, or with contaminated or potentially contaminated items. Appropriate mouth, nose, and eye protection, e.g., face masks, face shield is worn for resident care or procedures that are likely to contaminate mucous membranes or generate splashes or sprays of blood, body fluids, secretions, or excretions. PPE appropriately discarded after resident care prior to leaving room, followed by hand hygiene and supplies necessary for adherence to proper PPE use, e.g., gloves, gowns, masks, are readily accessible in resident care areas, i.e., nursing units, therapy rooms. Although equipment supply carts should not be brought into the resident's room, the facility must prevent infections through indirect contact transmission. This requires the decontamination, i.e., cleaning and or disinfecting an object to render it safe for handling of resident equipment, medical devices, and the environment. Alternatively, the facility may also consider using single-use disposable devices or designating reusable equipment for only an individual resident. Note: additional information related to environmental cleaning may be found in CDC and the Healthcare Infection Control Practices Advisory Committee's HICPAC Guidelines for Environmental Infection Control in Healthcare Facilities 2003 at https://www.cdc.gov/infectioncontrol/guidelines/environmental/index.html. Equipment or items in the resident environment likely to have been contaminated with infectious fluids or other potentially infectious matter must be handled in a manner so as to prevent transmission of infectious agents, e.g., wear gloves for handling soiled equipment and properly clean and disinfect or sterilize reusable equipment before use on another resident. 38. The CDC has adopted the Spaulding classification system that identifies 3 risk levels associated with medical and surgical instruments: critical, semi-critical, and non-critical. Items. Critical items, e.g., needles, intravenous catheters, indwelling urinary catheters. Enter sterile tissue or the vascular system. These items or equipment must be sterile when used, based on one of several accepted sterilization procedures. Sterilization destroys all viable microorganisms to prevent disease transmission. Associated with the use of that item, most of the items in this category should be purchased as sterile or be sterilized. Semi-critical items, e.g., dental, podiatry equipment, electric razors, contact, mucous membranes, or non-intact skin. Such items require meticulous cleaning, followed by high-level disinfection treatment using an FDA-approved high-level chemical disinfectant, or they may be sterilized. High-level disinfection is traditionally defined as complete elimination of all microorganisms in or on an instrument, except for small numbers of bacterial spores. Refer to the specific disinfectant label claim to determine effectiveness. And non-critical items are those that come in contact with intact skin, but not mucous membranes. Non-critical items are divided into non-critical resident care items, e.g., blood pressure cuffs, stethoscopes, wheelchairs, therapy equipment, and non-critical environmental surfaces, e.g., bed rails, bedside tables. Non-critical items require cleaning, followed by either low or intermediate level disinfection. Following manufacturer's instructions, disinfection should be performed with an EPA-registered disinfectant labeled for use in healthcare settings. All applicable label instructions on EPA-registered disinfectant products must be followed, e.g., use dilution, shelf life, storage material compatibility, safe use and disposal. 39. Low-level disinfection is traditionally defined as the destruction of all vegetative bacteria except tubercle bacilli and most viruses, some fungi, but not bacterial spores. Examples of low-level disinfectants include EPA registered hospital disinfectants with an HBV and HIV label claim. Low-level disinfection is generally appropriate for most non-critical equipment. Intermediate-level disinfection is traditionally defined as destruction of all vegetative bacteria, including tubercle bacilli, lipid and some non-lipid viruses, and fungi, but not bacterial spores. EPA-registered hospital disinfectants with a tuberculocidal claim are intermediate-level disinfectants. Given the broader spectrum of activity, intermediate-level disinfection should be considered for non-critical equipment that is visibly contaminated with blood. However, a low-level disinfectant with a label claim against HBV and HIV could also be used. 4041. Single-use disposable equipment is an alternative to reprocessing reusable medical instruments. Single-use devices must be discarded after use and are never used for more than one resident. Nursing homes may purchase reprocessed single-use devices when these devices are reprocessed by an entity or a third-party reprocessor that is registered with the FDA. The nursing home must have documentation from the third-party reprocessor that indicates that it has been cleared by the FDA to reprocess the specific device in question. Note: additional information related to disinfection and sterilization may be found in CDC's Guideline for Disinfection and Sterilization in Healthcare Facilities, 2008, at https://www.cdc.gov/infection control/guidelines/disinfection/index.html. Transmission-based precautions. There are 3 categories of transmission-based precautions: contact precautions, droplet precautions, and airborne precautions. Transmission-based precautions are used when the route of transmission is not completely interrupted using standard precautions. Alone, for some diseases that have multiple routes of transmission, more than one. Transmission-based precautions category may be required, whether used singly or in combination. They must always be used in addition to standard precautions. The type of PPE and precautions used depends on the potential for exposure, route of transmission, and infectious organism / pathogen or clinical syndrome if an organism is not yet identified. The diagnosis of many infections is based on clinical signs and symptoms, but often requires laboratory confirmation. However, since laboratory tests, especially those that depend on culture techniques, may require 2 or more days to complete, transmission-based precautions may need to be implemented while test results are pending, based on the clinical presentation and the likely category of pathogens. 4243. The facility should initiate transmission-based precautions for a constellation of new symptoms consistent with a communicable disease. Empirically initiated transmission-based precautions may be adjusted or discontinued when additional clinical information becomes available, e.g., confirmatory laboratory results. Facility policies must identify the type, i.e., contact, droplet, airborne, and duration of the transmission-based precautions required, depending upon the infectious pathogen involved. Residents on transmission-based precautions should remain in their rooms, except for medically necessary care. 44. Furthermore, transmission-based precautions should be the least restrictive possible for the resident based on his or her clinical situation, and used for the least amount of time. When used appropriately, transmission-based precautions is not to be considered involuntary seclusion. However, once the resident is no longer a risk for transmitting the pathogen, e.g., duration of the illness and / or can contain secretions, removing transmission-based precautions is required in order to avoid unnecessary, involuntary seclusion. Facility staff should take measures to reduce or minimize any potential psychosocial negative effects of isolation for whom transmission-based precautions are being used. Boredom, anger, withdrawal, or depression are just some of the mood changes that could occur. The facility must proactively ensure that individualized needs, e.g., activities, are met. Implementation of transmission-based precautions. When implementing transmission-based precautions, consideration should be given to the following: the identification of resident risk factors that increase the likelihood of transmission, such as uncontained secretions or excretions, noncompliance, cognition deficits, incontinence, etc. The provision of a private room as available / appropriate, cohorting residents with the same pathogen, and sharing a room with a roommate with limited risk factors, e.g., without indwelling or invasive devices, without open wounds, and not immunocompromised, as appropriate based on the pathogen and method of transmission. 45. When a resident is placed on transmission-based precautions, facility staff should implement the following: clearly identify the type of precautions and the appropriate PPE to be used. Place signage that includes instructions for use of specific PPE in a conspicuous location outside the resident's room, e.g., on the door or on the wall next to the doorway, wing, or facility-wide. Additionally, either the CDC category of transmission-based precautions, e.g., contact, droplet, or airborne, or instructions to see the nurse before entering should be included in signage. Ensure that signage also complies with residents' rights to confidentiality and privacy. Make PPE readily available near the entrance to the resident's room. Don appropriate PPE before or upon entry into the environment, e.g., room or cubicle of a resident on transmission-based precautions, e.g., contact. Precautions. Use disposable or dedicated non-critical resident care equipment, e.g., blood pressure cuff, bedside commode. If non-critical equipment is shared between residents, it will be cleaned and disinfected following manufacturer's instructions with an EPA-registered disinfectant after use. 46. Clean and disinfect objects and environmental surfaces that are touched frequently, e.g., bed rails, overbed table, bedside commode, lavatory surfaces, resident bathrooms with an EPA-registered disinfectant for healthcare use at least daily and when visibly soiled. 47. And provide education to residents to the degree possible / consistent with the residents' capacity and their representatives or visitors on the use of transmission-based precautions. Resources are available for current recommendations on standard and transmission-based precautions, such as guidelines for isolation precautions, preventing transmission of infectious agents in healthcare settings 2007, https://www.cdc.gov/infection control/guidelines/isolation/index.html, and management of multi-drug resistant organisms in healthcare settings 2006, https://www.cdc.gov/infection control/guidelines/mdro/index.html. Contact precautions. Contact precautions are intended to prevent transmission of pathogens that are spread by direct, e.g., person-to-person or indirect contact with the resident or environment, e.g., C. difficile, norovirus, scabies, and requires the use of appropriate PPE, including a gown and gloves before or upon entering, i.e., before making contact with the resident or resident's environment, the room or cubicle. Prior to leaving the resident's room or cubicle, the PPE is removed and hand hygiene is performed. Contact precautions should also be used in situations when a resident is experiencing wound drainage, fecal incontinence or diarrhea, or other discharges from the body that cannot be contained and suggest an increased potential for extensive environmental contamination and risk of transmission of a pathogen, even before a specific organism has been identified. Mdro colonization and infection. Contact precautions are used for residents infected or colonized with Mdro in the following situations: when a resident has wounds, secretions, or excretions that are unable to be covered or contained, and on units or in facilities where, despite attempts to control the spread of the Mdro, ongoing transmission is occurring. These strategies may differ depending on the prevalence or incidence of the Mdro in the facility and region. For example, additional usage of PPE can be used for residents who do not meet criteria for contact precautions but are infected or colonized with Mdro or have risk factors for Mdro acquisition. Staff can use gloves and gowns in order to prevent contamination of hands and clothing while performing high contact resident care activities that pose the highest risk for Mdro transmission. These high contact activities include dressing, bathing or providing hygiene, transferring, changing briefs or assisting with toileting, changing linens, or providing any type of device or wound care. Use of additional PPE during resident care would not restrict a resident's ambulation, socialization, and use of common areas and participation in group activities. Note: additional information related to Mdro may be found in CDC's implementation of personal protective equipment in nursing homes to prevent spread of novel or targeted multi-drug resistant organisms, Mdro at https://www.cdc.gov/high/containment/pp nursing homes HTML. Droplet precautions. The use of droplet precautions applies when respiratory droplets contain pathogens which may be spread to another susceptible individual. Respiratory pathogens can enter the body via the nasal mucosa, conjunctiva, and less frequently, the mouth. 48 examples of droplet-borne organisms that may cause infections include, but are not limited to, Mycoplasma pneumoniae, influenza, and other respiratory viruses. Respiratory droplets are generated when an infected person coughs, sneezes, talks, or during procedures such as suctioning, endotracheal intubation, cough induction by chest, physiotherapy, and cardiopulmonary resuscitation. 49. The maximum distance for droplet transmission is currently unresolved, but the area of defined risk based on epidemiological findings is approximately 3 to 10 feet. 50. In contrast to airborne pathogens, droplet-borne pathogens are generally not transmitted through the air over long distances. Face masks should be used upon entry into a residence room or cubicle with respiratory droplet precautions. 51. Based upon the pathogen or clinical syndrome, if there is risk of exposure of mucous membranes or substantial spraying of respiratory secretions is anticipated, gloves and gown as well as goggles or face shield in place of goggles should be worn. 52. The preference for a resident on droplet precautions would be to place the resident in a private room. 53. If a private room is not available, the resident could be cohorted with a resident with the same infectious agent if it becomes necessary for a resident who requires droplet precautions to share a room with a resident who does not have the same infection. The facility should make decisions regarding resident placement on a case-by-case basis after considering infection, risks to other residents in the room, and available alternatives. 54. Spatial separation and drawing the curtain between resident beds is especially important for residents in multi-bedrooms with infections transmitted by the droplet route. 55. A resident who is on droplet precautions for the duration of the illness, e.g., influenza, should wear a face mask, e.g., surgical or procedure face mask when leaving his or her room. Airborne precautions. Airborne transmission occurs when pathogens are so small that they can be easily dispersed in the air, and because of this, there is a risk of transmitting the disease through inhalation. These small particles containing infectious agents may be dispersed over long distances by air currents and may be inhaled by individuals who have not had face-to-face contact with or been in the same room with the infectious individual. Staff caring for residents on airborne precautions should wear a fit-tested N95 or higher level respirator that is donned prior to room entry. 56. Note, according to the CDC, preventing the spread of pathogens that are transmitted by the airborne route requires the use of special air handling and ventilation systems, such as an airborne infection isolation room, IR, to contain and then safely remove the infectious agent. 57. Residents with infections requiring an IR must be transported to an acute care setting, unless the facility can place the resident in a private IR room with the door closed. In cases when IR is required, such as for a resident with TB, it is important for the facility to have a plan, e.g., public health notification and exposure workup, in place to effectively manage a situation involving a resident with suspected or active TB while awaiting the resident's transfer to an acute care setting. 58. Medical device safety. Medical devices may be used for administration of medications, point-of-care testing, or for other medical uses. Point-of-care testing. Point-of-care testing is diagnostic testing that is performed at or near the site of resident care. This may be accomplished through use of portable, handheld instruments such as blood glucose meters or prothrombin time meters. This testing may involve obtaining a blood specimen from the resident using a fingerstick device. The guidance regarding fingerstick devices and blood glucose meters is applicable to other point-of-care devices, where a blood specimen is obtained, e.g., prothrombin time meters. Fingerstick devices. CDC recommends the use of single-use, auto-disabling fingerstick devices in settings where assisted blood glucose monitoring is performed. This practice prevents inadvertent reuse of fingerstick devices for more than one person. Additionally, the use of single-use, auto-disabling fingerstick devices protects healthcare staff from needle stick injuries. If reusable fingerstick devices are used for assisted monitoring of blood glucose, then they must never be used for more than one resident, although the package instructions for some fingerstick devices may indicate or imply the potential for multiple resident use. CMS guidance, based upon nationally recognized standards of practice from the CDC and FDA, prohibits the use of fingerstick devices for more than one resident. Note, if fingerstick devices are used on more than one resident, surveyors must cite at this tag and utilize the guidelines in Appendix Q for immediate jeopardy. Furthermore, the SA must notify the appropriate local/state public health authority of the deficient practice. Resources are available on fingerstick safety, such as CDC Clinical Reminder. Use of fingerstick devices on more than one person poses risk for transmitting bloodborne pathogens. https://www.cdc.gov/injection/fingerstick-devices/html and CDC's frequently asked questions facts regarding assisted blood glucose monitoring and insulin administration. https://www.cdc.gov/injection/providers/blood glucose monitoring facts HTML. Blood glucose meters. Blood glucose meters can become contaminated with blood, and if used for multiple residents, must be cleaned and disinfected after each use, according to manufacturers' instructions for multi-patient use. Additionally, staff must not carry blood glucose meters in pockets. The FDA has released guidance for manufacturers regarding appropriate products and procedures for cleaning and disinfection of blood glucose meters. FDA Letter 2. Manufacturers of blood glucose monitoring systems listed with the FDA can be found at http://www.fda.gov/medical-devices/products-and-medical procedures/in vitro diagnostics/ UCM 227935, HTM. An excerpt from this guidance reads, the disinfection solvent you choose should be effective against HIV, hepatitis C, and hepatitis B virus. Outbreak episodes have been largely due to transmission of hepatitis B and C viruses. However, of the two, hepatitis B virus is the most difficult to kill. Please note that 70% ethanol solutions are not effective against viral bloodborne pathogens, and the use of 10% bleach solutions may lead to physical degradation of your device. A list of Environmental Protection Agency EPA-registered disinfectants can be found at the following website: https://www.epagov/pesticide registration/selected EPA-registered disinfectants. Furthermore, healthcare personnel should consult the manufacturers of blood glucose meters in use at their facilities to determine what products, meeting the criteria specified by the FDA, are compatible with their meter prior to using any EPA-registered disinfectant for disinfection purposes, if manufacturers are unable to provide this information, then the meter should not be used for multiple patients. 59. Blood glucose meters, dedicated for single resident use, should be stored in a manner that will protect against inadvertent use of the device for additional residents and also cross-contamination via contact with other meters or equipment. Note, if the facility failed to clean and disinfect blood glucose meters per device and disinfectant manufacturer's instructions for use, they are used for more than one resident, and there is a resident with a known bloodborne pathogen in the facility, surveyors must cite noncompliance under this tag and utilize the guidelines in Appendix Q for determining immediate jeopardy. Furthermore, the SA must notify the appropriate local/state public health authority of this practice. Other instances of deficiencies may meet the definition of immediate jeopardy. Utilize guidelines in Appendix Q to make this determination. Note, additional information related to point-of-care testing may be found in CDC's infection prevention during blood glucose monitoring and insulin administration website at https://www.cdc.gov/injection/blood glucose monitoring HTML. Safe medication administration. All injectable medications must be prepared and administered in accordance with safe injection practices, which include but are not limited to the following. Injections are prepared using aseptic technique in a clean area, free from potential sources of contamination, e.g., blood, body fluids, contaminated equipment. Needles and syringes are used for only one resident. This includes manufactured prefilled syringes and cartridge devices, such as insulin pens. Note, if it is identified that needles or syringes are used for more than one resident, surveyors must cite noncompliance at this tag and utilize the guidelines in Appendix Q for determining immediate jeopardy. The SA must notify the appropriate local/state public health authority of the deficient practice. Medication containers are entered with a new needle and a new syringe, even when obtaining additional doses for the same resident. If noncompliance is found, further investigation is warranted. Note, if the medication container is used for more than one resident, a new needle and / or syringe was not used with each access, and the container was then used for another resident, surveyors must cite noncompliance at this tag and utilize the guidelines in Appendix Q for determining immediate jeopardy. The SA must notify the appropriate local/state public health authority of the deficient practice. Single-dose, single-use medication vials, ampules, and bags or bottles of intravenous solution are used for only one resident. Medication administration tubing and connectors are used for only one resident. Note, surveyors must cite at this tag if noncompliance is identified and utilize the guidelines in Appendix Q for determining immediate jeopardy. The SA must notify the appropriate local/state public health authority of the deficient practice, and multi-dose vials to be used for more than one resident are kept in a centralized medication area, e.g., medication room or cart, and do not enter the immediate resident treatment area, e.g., resident room. If multi-dose vials enter the immediate resident treatment area, they should be discarded immediately after use. Note, additional information related to multi-dose vials may be found in CDC's questions about multi-dose vials website at https://www.cdc.gov/injection/providers/provider fax multivials HTML. Insulin pens are pen-shaped injector devices that contain a reservoir for insulin or an insulin cartridge. These devices are designed to permit self-injection and are intended for single-person use, using a new needle for each injection. Insulin pens are designed to be used multiple times by a single resident only and must never be shared. Facility staff must follow manufacturer's instructions for administration. Regurgitation of blood into the insulin cartridge after injection will create a risk of bloodborne pathogen transmission if the pen is used for more than one resident, even when the needle is changed. The FDA makes the following recommendations to prevent transmission of bloodborne infections in residents who require insulin pens. Insulin pens containing multiple doses of insulin are meant for single resident use only and must never be used for more than one person, even when the needle is changed. Insulin pens must be clearly labeled with the resident's name and other identifiers to verify that the correct pen is used on the correct resident, and facilities should review their policies and procedures and educate their staff regarding safe use of insulin pens. Note, sharing insulin pens or similar devices between residents is similar to reusing needles or syringes for more than one resident. If noncompliance is found, surveyors must cite at this tag and utilize the guidelines in Appendix Q for determining immediate jeopardy. The SA must notify the appropriate local/state public health authority of the finding. Note, additional information related to insulin pens may be found in FDA's drug safety communication. FDA requires label warnings to prohibit sharing of multi-dose diabetes pen devices among patients at https://www.fda.gov/drugs/drug safety/UCM 435271 HTM. Accessing vascular devices. Vascular access devices, especially central venous catheters (CVC), increase the risk for local and systemic infections, as well as additional complications such as septic thrombophlebitis. Intravascular access devices such as implanted ports may be accessed multiple times per day for hemodynamic measurements or to obtain samples for laboratory analysis, thus increasing the risk of contamination and subsequent clinical infection. Limiting access to CVCs for only the primary purpose may help reduce the risk of infection. Resources are available for current standards of practice for the care of CVCs such as CDC's Basic Infection Control and Prevention Plan for Outpatient Oncology. Settings: https://www.cdc.gov/high/settings/outpatient/basic infection control. Prevention Plan 2011/index.html. CDC's Hemodialysis Central Venous Catheter Scrub the Hub Protocol. http://www.cdc.gov/dialysis/pdfs/collaborative/hemodialysis central venous catheter SDH protocol PDF. CDC's Audit Tool Catheter Exit Site Care Observations. http://www.cdc.gov/dialysis/pdfs/collaborative/catheter exit site care observations PDF, and CDC's Guidelines for the Prevention of Intravascular Catheter-Related Infections 2011. https://www.cdc.gov/infection-control/guidelines/index.html/BSI guidelines 2011 PDF. System of Recording IP Incidents. A facility must develop and implement a system for recording incidents identified under the facility's IP and the corrective actions taken by the facility based on the investigation of the incidents in accordance with Section 483.80A4. A facility identified. Incident e.g. High may include the spread of disease due to errors and infection. Prevention and control. The facilities system should include defining, identifying, analyzing, and reporting incidents related to failures in infection control practices to the Director of Nursing, Medical Director, and the QAA Committee. These may include but are not limited to the following: identification of methods by which the facility would obtain information on incidents from residents, family, and direct care/direct access staff. A description of how the facility addresses and investigates the incident tests. Measures to be implemented for the prevention of incidents or potential incidents as they relate to infection prevention and control. Development and implementation of corrective actions. Monitoring for the effectiveness of its implemented changes, and methods for feedback to appropriate individuals involved in the failed practices. Linens. Laundry services. Under Section 483.80E, the facility must develop and follow practices on handling, storing, processing, and transporting laundry so as to prevent the spread of infection. The facility must monitor to ensure that the laundry practices are implemented. Any deviations from practices must be identified, and corrective actions are put in place. Laundry includes residents' personal clothing, linens, i.e., sheets, blankets, pillows, towels, washcloths, and items from departments such as nursing, dietary, rehabilitative services, beauty shops, and environmental services. Laundry services may be provided on-site, or the facility may have a written agreement in place for off-site laundry services, regardless of the location where the laundry is processed. The facility must ensure that all laundry is handled, stored, processed, and transported in a safe and sanitary manner. Handling laundry. The facility staff should handle all used laundry as potentially contaminated and use standard precautions, e.g., gloves, gowns when sorting and rinsing. The facility should use the following practices. 60. Contaminated laundry is bagged or contained at the point of collection, i.e., location where it was used. Leak-resistant containers or bags are used for linens or textiles contaminated with blood or body substances. Sorting and rinsing of contaminated laundry at the point of use, hallways, or other open resident care spaces is prohibited, and staff should handle soiled textiles/linens with minimum agitation to avoid the contamination of air, surfaces, and persons. Transport of laundry. The facility practices must include how staff will handle and transport the laundry with appropriate measures to prevent cross-contamination. This includes, but is not limited to, the following: contaminated linen and laundry bags are not held close to the body when transporting. No special precautions, e.g., double bagging, melting bags, or categorizing, e.g., biohazard, color-coded for linen originating in transmission-based precaution. Rooms is necessary. 61. Double bagging of linen is only recommended if the outside of the bag is visibly contaminated or is observed to be wet through to the outside of the bag. 62. Contaminated linen carts must be cleaned and disinfected whenever visibly soiled, and according to a schedule developed by the facility. Separate carts must be used for transporting clean and contaminated linen. If this is not possible, the contaminated linen cart should be thoroughly cleaned and disinfected per facility protocol before being used to move clean linens. And 63. Clean linens must be transported by methods that ensure cleanliness and protect from dust and soil during intra- or interfacility loading, transport, and unloading. 64. Linen storage. Facility practices must address linen storage and should include, but are not limited to, covers are not needed on contaminated textile hampers in resident care areas, unless state licensing rules require them. 65 and clean linen must always be kept separate from contaminated linen. The use of separate rooms, closets, or other designated spaces with a closing door provides the most secure methods for reducing the risk of accidental contamination. Processing laundry, including the use of laundry equipment and detergents in the facility. The facility must have a process to clean laundry. Detergent and water physically remove many microorganisms from the linen through dilution during the wash cycle. Advances in laundry equipment technology allow modern-day detergents to be much more effective, removing soil and reducing the presence of microbes than those used in the past when much of the research on laundry processing was first conducted. Washing/drying processes includes the use of manufacturer's instructions for use IFU for laundry, additives, and equipment maintenance. The facility staff must prevent contamination of laundry in processing areas. The facility has laundry practices that include, but are not limited to the following: 66. Availability and use of hand hygiene products, as well as appropriate PPE, i.e., gloves and gowns, while sorting and handling contaminated linens. The receiving area for contaminated textiles is clearly separated from clean laundry areas. Workflow should prevent cross-contamination. If using fans in laundry processing areas, prevent cross-contamination of clean linens from air blowing from soiled processing areas, i.e., the ventilation should not flow from soiled processing areas to clean laundry areas. Laundry equipment, e.g., washing machines, dryers, is used and maintained according to the manufacturer's IFU to prevent microbial contamination of the system. Damp laundry is not left in machines overnight. Laundry detergents, rinse aids, or other additives are used according to the manufacturer's IFU. Note: facilities should communicate information regarding allergies that may impact how an individual resident's laundry is processed. Ozone cleaning systems are acceptable for processing laundry. If laundry chutes are used, they are designed and maintained so as to minimize dispersion of aerosols from contaminated laundry, e.g., no loose items in the chute and bags are closed before tossing into the chute, and the facility should be using the fabric manufacturer's recommended laundry cycles, water temperatures, and chemical detergent products. Recommendations for laundry processed in hot water temperatures is 160 F71 C for 25 minutes, and for laundry that is not hot water compatible, low temperature washing at 71 to 77 F22 to 25 C plus chlorine or oxygen-activated bleach can reduce microbial contamination. Note: the facility is not required to monitor water temperatures during laundry processing cycles unless specified by state rules. A chlorine bleach rinse is not required for all laundry items processed in low-temperature washing environments due to the availability of modern laundry detergents that are able to produce hygienically clean laundry without the presence of chlorine bleach. The facility should refer to the manufacturer's recommendations for the use of the detergent and items being laundered. Off-site professional laundry services. If linen is sent off-site to a professional laundry, the facility has practices that address how the service will be provided, including how linen is processed and handled to prevent contamination from dust and dirt during loading and transport. The facility should assure that this laundry service meets healthcare industry laundry standards. Mattresses and pillows. Standard permeable mattresses and pillows can become contaminated with body Substances during resident care if the integrity of the covers of these items is compromised. A mattress cover is generally a fitted protective material, the purpose of which is to prevent the mattress from becoming contaminated with body fluids and substances. A linen sheet placed on the mattress is not considered a mattress cover. Patches for tears and holes in mattress covers do not provide an impermeable surface over the mattress. Note, bed and bath linens must be maintained in good condition. Refer to Section 483.10 I Safe Environment, F884, for further information. The facility must have practices that address the methods for cleaning and disinfecting items that are to be used for another resident after an individual resident's use. Such practices 67 include, but are not limited to, the following. Mattress covers with tears or holes are replaced. Moisture-resistant mattress covers are cleaned and disinfected between use for different residents with an EPA-approved germicidal detergent to help prevent the spread of infections. Fabric mattress covers are laundered between use for different residents. Pillow covers and washable pillows are laundered in a hot water laundry cycle between use for different residents or when they become contaminated with body substances, and mattresses are discarded if bodily fluids have penetrated into the mattress fabric. Annual review of IPC. Under Section 483.80F, the facility's IPC and its standards, policies, and procedures must be reviewed at least annually to ensure effectiveness and that they are in accordance with current standards of practice for preventing and controlling infections. The IPC must be updated as necessary. In addition, the facility population and characteristics may change over time, and the facility assessment may identify components of the IPC that must be changed accordingly. Investigative procedures. Use the infection prevention, control, and immunizations facility task, along with the above interpretive guidance, when determining if the facility meets the requirements for, or when investigating concerns related to, infection prevention and control. One surveyor should coordinate the review of the facility's overall IPC. However, each member of the survey team should assess for compliance throughout the entire survey when observing his or her assigned areas and tasks. The IPC must be facility-wide and include all departments and contracted services. If potential noncompliance is identified, the surveyor should corroborate those concerns through observations, interviews, and record and or document review. Observations. Specific observations for the provision of infection prevention and control practices, such as following standard precautions, e.g., hand hygiene and the appropriate use of PPE, should be made by all team members throughout the survey. Observe care of residents on transmission-based precautions, if any, to determine if implemented appropriately. Based on precaution type, i.e., contact, droplet, airborne, if concerns are identified, expand the sample to include more residents on transmission-based precautions. Observe laundry services throughout the survey, e.g., resident and laundry rooms too. Determine whether staff handle, store, process, and transport linens appropriately. Interviews. Surveyors should interview appropriate facility staff regarding the IPC. In addition, any potential concerns should be followed up with interviews and record reviews as needed. Potential tags for additional investigation. F845, for concerns related to staff training on the standards, policies, and procedures of the Infection Prevention and Control Program. F826, for staff competency concerns related to nursing services. F841, for staff competency concerns related to behavioral health staff caring for residents with dementia, or a history of trauma and / or post-traumatic stress. Disorder. F801 for staff competency concerns related to food and nutrition staff. F839 for staff competency concerns related to administration for any other staff. Not referenced above. F550 and F675 for concerns related to the overuse of transmission-based. Isolation precautions. 2. The inappropriate transferring of rooms unnecessarily. Or 3. The inappropriate use of PPE such as gloves when used unnecessarily, where residents indicate they are untouchable, dirty, or unclean. F603 for concerns related to possible involuntary seclusion. F755 for concerns related to reconciliation of data from injectable, scheduled. Drug tracking. F867 for concerns related to the QAA committee's responsibility to identify or correct quality deficiencies, which may include systemic infection control. Concerns. F841 for concerns related to the medical director's role in responsibility for care. F684 for concerns related to the provision of wound care. F686 for concerns related to the provision of pressure ulcer care. F690 for concerns related to the provision of urinary catheter care. F694 for concerns related to the administration of parenteral fluids, and F695 for concerns related to the provision of respiratory care. Key elements of noncompliance. To cite deficient practice at F880, the surveyor's investigation will generally show that the facility failed to do any one or more of the following: establish and maintain an IP designed to provide a safe, sanitary, and comfortable environment and to help prevent development and transmission of disease and infection, or the IP must be reviewed at least annually and updated as necessary, or implement a system for preventing, identifying, reporting, investigating, and controlling infections and communicable diseases for all residents, staff, volunteers, visitors, and other individuals providing services under a contractual arrangement based on the Facility Assessment C Section 483.71 and follows accepted national standards, or develop and implement written IP standards, policies, and procedures that are current and based on national standards. These must include when and to whom possible incidents of communicable diseases should be reported, or developing and implementing a system of surveillance to identify infections or communicable diseases, or how to use standard precautions to include appropriate hand hygiene, and how and when to use transmission-based precautions, i.e., isolation precautions, or prohibiting staff with a communicable disease or infected skin lesions from direct contact with residents or their food if direct contact will transmit disease, or assure that staff handle, store, process, and transport laundry to prevent the spread of infection, or maintain a system for recording identified incidents and taking appropriate corrective actions. Deficiency categorization. Examples of Level 4 immediate jeopardy to resident health and safety include, but are not limited to: the facility failed to follow standard precautions during the performance of routine testing of blood glucose. The facility reused fingerstick devices for more than one resident. This practice of reusing fingerstick devices for more than one resident created an immediate jeopardy to resident health by potentially exposing residents who required blood glucose testing to the spread of blood-borne infections in the facility. The facility failed to investigate, document surveillance of, and implement preventative measures to address an outbreak of gastrointestinal illness among residents in one unit of the facility. As a result, several residents in an adjoining unit became seriously ill with diarrheal illnesses resulting in dehydration. The facility failed to provide a safe and sanitary environment. Staff failed to handle linens so as to prevent the spread of infection. Staff rinsed contaminated linens in the resident's sink instead of in the facility's dedicated area. Furthermore, the staff did not clean and disinfect the bathroom sink after rinsing soiled clothing and linens in the shared bathroom sink. A resident was observed to have an acute onset of vomiting and diarrhea, resulting in soiled clothing and linens. The nursing staff removed the soiled/contaminated clothing and linens, rinsed them out in the bathroom sink, and placed the wet/soiled linen onto the floor. The bathroom was shared with a roommate who utilized the sink for oral hygiene purposes and stored his or her toothbrush and glass on the sink. The roommate subsequently developed vomiting and diarrhea with the development of severe dehydration, resulting in hospitalization. The facility failed to ensure that its staff demonstrated the proper use of gloves with hand hygiene between residents to prevent the spread of infection. The registered nurse, RN, was observed wearing gloves while providing direct care to a resident who was on contact precautions for an infection with a multi-drug resistant organism. The RN left the room after removing the gloves but did not conduct hand hygiene, went to a second resident and started providing direct care. As a result, the second resident was likely exposed through indirect contact transmission to the MDRO, creating the likelihood of serious injury, serious harm, serious impairment, or death. Examples of Level 3 actual harm that is not immediate jeopardy include, but are not limited to: the facility failed to identify and prevent the spread of infestation when a case of scabies, i.e., a highly contagious skin condition caused by the itch mite sarcops, scabiei, was not diagnosed or adequately treated, and the resident was not placed on transmission-based precautions. Resident A was admitted with an undiagnosed, reddened, itchy pinpoint rash which spread, became infected, and disrupted the resident's sleep. A month later, multiple residents developed a red pinpoint rash with severe itching, which was not present prior to resident A being admitted. The facility failed to identify through assessment and therefore implement control measures to prevent the transmission of scabies among multiple residents in the facility, causing the residents physical harm. In addition to the physical harm, the residents experienced psychosocial harm due to anxiety and loss of sleep from severe itching and lack of timely diagnosis. The facility failed to ensure that linens were handled and processed in a manner to prevent the spread of pediculosis, i.e., head lice, after a resident A in a semi-private room was diagnosed with pediculosis. Staff were aware of the presence of pediculosis, but did not handle the resident's linens or clothing appropriately, removing bed linens and placing them on the roommate's chairs and other furnishings. The resident's roommate, resident B, became infested with pediculosis. The resident's roommate was nonverbal and unable to express that he had intense itching and began to scratch himself. Examples of Level 2: no actual harm with potential for more than minimal harm that is not immediate jeopardy include, but are not limited to: the facility failed to ensure that its staff demonstrates proper use of gloves with hand hygiene between residents to prevent the spread of infections. The nurse administered medications to a resident via a gastric tube, and while wearing the same gloves proceeded to administer oral medications to another resident. The nurse did not remove the used gloves nor perform hand hygiene between F880 residents. The facility failed to implement appropriate measures for the transport of contaminated linens. As a result, the potential exists for transmission of organisms from contaminated uniforms to residents during the delivery of care. A nursing assistant was observed removing bed linens contaminated with urine and fecal material without the use of gloves and gown, and carrying the contaminated linens against his or her uniform to the laundry bin. The nursing assistant proceeded to assist the resident's roommate with transferring to his or her chair, and his or her uniform made contact with the resident's skin and clothing. The facility failed to ensure that a staff member implemented appropriate processes related to handling and storing wound care supplies. As a result, the potential existed for transmission of organisms between residents who received dressing changes. A staff member who was providing wound care was observed to place dressing supplies on one resident's bedding, and after completing the dressing change, place the supplies, which are used for other residents, in the unit's dressing cart. An example of Level 1, no actual harm with potential for minimal harm includes, but is not limited to, the facility failed to ensure that the IPC program was reviewed annually. The survey was conducted, and it was determined that the facility last reviewed the IPC at 14 months instead of annually, i.e., 12 months. There were no infection control findings outside of annual review and documentation. 1 Siegel J.D., Reinhardt E., Jackson M., Chiarello L., and the Healthcare Infection Control Practices Advisory Committee Guideline for Isolation Precautions, Preventing Transmission of Infectious Agents in Healthcare Settings 2007, accessed on February 27, 2021 from https://www.cdc.gov/infection-control/guidelines/isolation/index.html. 2C and Note 1. 3C and Note 1. 4C and Note 1. 5 Centers for Disease Control and Prevention. Guideline for Disinfection and Sterilization in Healthcare Facilities 2008. Accessed on February 27, 2021 from https://www.cdc.gov/hicpac/pdf/guidelines/disinfection NOV 2008 PDF. 6C and Note 5. 7 Centers for Disease Control and Prevention 2002, October 25. Guideline for Hand Hygiene in Health Care Settings. Recommendations of the Healthcare Infection Control Practices Advisory Committee and the HICPAC/SHE/APIC/IDSA Hand Hygiene Task Force, MMWR 51 NORR 16, accessed on February 27, 2021 from http://www.cdc.gov/mmwr/pdf/rr/rr 5116 PDF. 8 Centers for Disease Control and Prevention. Hand Hygiene in Healthcare Settings. www.cdc.gov. Accessed on February 27, 2021 from https://www.cdc.gov/handhygiene/providers/index.html. Reference was updated from SOM Rev. 173. 9 Association for the Advancement of Medical Instrumentation AMI, 2009, ANSI/AMI. Since 65, 2008/ART 2013. Processing of Reusable Surgical Textiles for Use in Health Care Facilities, 2008. Arlington, VA. 10C and Note 1. 11 Healthcare Infection Control Practices Advisory Committee HICPAC, 2017. Core Infection Prevention and Control Practices for Safe Healthcare Delivery in All Settings. Recommendations of the HICPAC, www.cdc.gov. Accessed on February 27, 2021 from https://www.cdc.gov/ HICPAC/recommendations/core practices HTML. 12C and Note 1. 13C and Note 1. 14 Association for Professionals in Infection Control and Epidemiology. IC Risk Assessment Tool Form and IC Risk Assessment Analysis. Accessed on February 27, 2021 from http://communityapicorg/sierra/resources/overview. 15C and Note 1. 16C and Note 11. 17 Duberk, ER, and Jerding, DN. Rationale for hand hygiene recommendations after caring for a patient with Clostridium difficile infection. A compendium of strategies to prevent healthcare-associated infections in acute care hospitals. A fall 2011 update. https://www.shayonline.org/accessed on February 27, 2021 from https://www.shayonline.org/images/patients/CDI hand hygiene update PDF. 18C and Note 1. 19C and Note 1. 20C and Note 1. 21 Bolliard, EA, Tablin OC, Williams WW, Pearson ML, Shapiro CN, Deichmann SD, and the Healthcare Infection Control Practices Advisory Committee. Guideline for Infection Control in Health Care Personnel, 1998. www.cdc.gov accessed on February 27, 2021 from https://www.cdc.gov/hicpac/pdf/infect control98 PDF. 22 Qhar DT, Carico R, Cox K. DePirio MA, Irwin KL, Lundstrom T, and the Healthcare Infection Control Practices Advisory Committee, 2019. Infection Control in Healthcare Personnel. Infrastructure and Routine Practices for Occupational Infection Prevention and Control Services. www.cdc.gov, accessed on February 27, 2021 from https://www.cdc.gov/infection-control/guidelines/healthcare personnel/index HTML. 23 Sosa LE, Njai GJ, Lobato MN, Morris SB, Butchta W, and Casey ML. Tuberculosis Screening, Testing, and Treatment of U.S. Healthcare Personnel. Recommendations from the National Tuberculosis Controllers Association and CDC, 2019. MMWR 68, 439 Section 443. Accessed on February 27, 2021 from https://www.cdc.gov/tb/publications/guidelines/infection control HTM. 24 Stone ND, Ashraf MS, Calder J, Ciarnish CJ, Crossley K, Drinka PJ, Bradley SF, 2012. Surveillance Definitions of Infections in Long-Term Care Facilities, Revisiting the Mujir Criteria. Infect Control HOSP Epidemiology, 3310, 965-977. 25C and Note 1. 26 Siegel J.D., Reinhardt E., Jackson M., and Chiarello L. Management of Multidrug-Resistant Organisms in Healthcare Settings 2006. www.cdc.gov. Accessed on February 27, 2021 from https://www.cdc.gov/hicpac/pdf/mdro/mdro guideline 2006 PDF. 27 Smith PW, Bennett G, Bradley S, Drinka P, Lautenbach E, Marks J, Stevenson K 2008. Shea/APIC Guideline, Infection Prevention and Control in the Long-Term Care Facility. Infect Control HOSP Epidemiology, 29-9, 785-814. 28 GA A, Carling, P. and Environmental Evaluation Workgroup, 2010. Options for evaluating environmental cleaning. www.cdc.gov. Accessed on February 27, 2021 from https://www.cdc.gov/hi/toolkits/evaluating environmental cleaning HTML. 29. See and Note 24. 30C and Note 27. 31 Centers for Disease Control and Prevention. Epidemiology Glossary. www.cdc.gov. Accessed on February 27, 2021 from http://www.cdc.gov/reproductive/health/data stats/glossary HTML#0. 32 Kim KH, Fekete R, Batts DH, Brown D, Cudmore M, Silva J, JR, and Waters D. 1981 January. 1. Isolation of Clostridium difficile from the environment and contacts of residents with antibiotic. Associated colitis. Journal of Infectious Disease, 143 1, 42-50. 33 Centers for Disease Control and Prevention. Hepatitis B questions and answers for health professionals. www.cdc.gov. Accessed on February 27, 2021 from http://www.cdc.gov/hepatitis/hbv/hbvfachtm. 34 Centers for Disease Control and Prevention CDC. H1N1 flu, general info. www.cdc.gov. Accessed on February 27, 2021 from https://www.cdc.gov/h1n1 flu/khtm. 35 See and Note 1. 36 See and Note 11. 37 See and Note 11. 38 See and Note 1. 39 See and Note 5. 40 See and Note 5. 41 Seholster LM, Chin RY, Arduino MJ, Carpenter J, Donlin R, Ashford D, Cleveland J. 2003, updated July 2019. Guidelines for Environmental Infection Control in Healthcare Facilities. 2003, www.cdc.gov. Accessed on February 27, 2021 from https://www.cdc.gov/infection control/guidelines/environmental/index.html. 42 See and Note 1. 43 See and Note 26. 44 See and Note 1. 45 See and Note 1. 46 See and Note 1. 47 See and Note 1. 48 Hall CB, Douglas JR, RG, Schnabel KC, and Jamin JM. 1981 September. Infectivity of respiratory syncytial virus by various routes of inoculation. Infection and immunity. 33.3, 779-783. 49 See and Note 1. 50 See and Note 1. 51 See and Note 1. 52 See and Note 1. 53 See and Note 1. 54 See and Note 1. 55 See and Note 1. 56 See and Note 1. 57 See and Note 1. 58 See and Note 1. 59 Centers for Disease Control and Prevention. Frequently asked questions, facts regarding assisted blood glucose monitoring and insulin administration. www.cdc.gov. Accessed on February 27, 2021. From https://www.cdc.gov/injection/providers/blood glucose monitoring fax HTML. 60 See and Note 41. 61 See and Note 41. 62 Occupational Safety and Health Administration. Title 29 Part 1910.1030 Bloodborne Pathogens. Accessed on February 27, 2021 from http //www.ecforgov/cgibin/text. IDX SID equals 4E5245 F66094 D270 BC2 BD 93105 F6A92D and MC equals true and node equals C29.6.19 1011,030 and RGN equals div8. 63C and note 41. 64C and note 41. 65C and note 41. 66C and note 41. 67C and note 41. Tag F881. Section 483.8 0A Infection Prevention and Control Program. The facility must establish an Infection Prevention and Control Program IPC that must include, at a minimum, the following elements. Section 483.8 0A3 An antibiotic stewardship program that includes antibiotic use, protocols, and a system to monitor antibiotic use. Intent. The intent of this regulation is to ensure that the facility develops and implements protocols to optimize the treatment of infections by ensuring that residents who require an antibiotic are prescribed the appropriate antibiotic, reduces the risk of adverse events, including the development of antibiotic-resistant organisms from unnecessary or inappropriate antibiotic use, and develops, promotes, and implements a facility-wide system to monitor the use of antibiotics. Definitions. Antibiotic refers to a medication used to treat bacterial infections. They are not effective for infections caused by viruses, e.g., influenza or most cases of bronchitis. Antibiotic stewardship refers to a set of commitments and actions designed to optimize the treatment of infections while reducing the adverse events associated with antibiotic use. Point 1. This can be accomplished through improving antibiotic prescribing, administration, and management practices, thus reducing inappropriate use to ensure that residents receive the right antibiotic for the right indication, dose, and duration. Point 2. Methicillin-resistant Staphylococcus aureus MRSA aka oxacillin-resistant Staphylococcus aureus refers to Staphylococcus aureus bacteria that are resistant to treatment with one of the semi-synthetic penicillins, e.g., oxacillin/nafcillin/methicillin. Vancomycin-resistant Enterococcus vri refers to a species of Enterococcus which have developed resistance to the antibiotic vancomycin. Guidance. Antibiotic stewardship. As part of their IPC programs, facilities must develop an antibiotic stewardship program that promotes the appropriate use of antibiotics and includes a system of monitoring to improve resident outcomes and reduce antibiotic resistance. 3, 4, 5. This means that the antibiotic is prescribed for the correct indication, dose, and duration to appropriately treat the resident, while also attempting to reduce the development of antibiotic-resistant organisms. Nursing home residents are at risk for adverse outcomes associated with the inappropriate use of antibiotics that may include, but are not limited to, the following: increased adverse drug events and drug interactions, e.g., allergic rash, anaphylaxis or death, serious diarrheal infections from C. difficile, disruption of normal flora, e.g., this can result in overgrowth of candida such as oral thrush and slash, or colonization and slash or infection with antibiotic-resistant organisms such as MRSA, vri, and multi-drug-resistant gram-negative bacteria. Resources are available to identify core actions to prevent antibiotic resistance within the control of the nursing home, such as the Centers for Disease Control and Prevention's CDC, the core elements of antibiotic stewardship for nursing homes. http://www.cdc.gov/longtermcare/pdfs/core elements antibiotic stewardship. Appendix: a PDF, and the Agency for Healthcare Research and Quality's Nursing Home Antimicrobial Stewardship Guide, http://www.gov/nhguide/index.html for examples of antibiotic use protocols, policies, and practices. Note: references to non-CMS sources are provided as a service and do not constitute or imply endorsement of these organizations or their programs by CMS or the U.S. Department of Health and Human Services (HHS). CMS is not responsible for the content of pages found at these sites. URL addresses and reference documents were current as of the date of this publication. Guidelines change, and facilities are responsible for following the most current standards. Antibiotic Stewardship Program (ASP). As summarized by the CDC, the core elements for antibiotic stewardship in nursing homes include facility leadership commitment to safe and appropriate antibiotic use, appropriate facility staff accountable for promoting and overseeing antibiotic stewardship, accessing pharmacists and others with experience or training in antibiotic stewardship, implement policy-wise or practice to improve antibiotic use, track measures of antibiotic use in the facility, i.e., one process and one outcome. Measure regular reporting on antibiotic use and resistance to relevant staff such as prescribing clinicians and nursing staff, and educate staff and residents about antibiotic stewardship. Point 6. The facility must develop an antibiotic stewardship program, which includes the development of protocols and a system to monitor antibiotic use. This development should include leadership support and accountability via the participation of the medical director, consulting pharmacist, nursing and administrative leadership, and individual with designated responsibility for the infection control program, i.e., infection preventionist. Point 7. The antibiotic stewardship program protocols shall describe how the program will be implemented and antibiotic use will be monitored. Consequently, protocols should be incorporated in the overall infection prevention and control program, be reviewed on an annual basis, and as needed, contain a system of reports related to monitoring antibiotic usage and resistance. Data examples may include the following: summarizing antibiotic use from pharmacy data or electronic health records, such as the rate of new starts, types of antibiotics prescribed, or days of antibiotic treatment per 1,000 resident days. Summarizing antibiotic resistance, e.g., antibiogram based on laboratory data from, for example, the last 18 months, and or tracking measures of outcome surveillance related to antibiotic use, e.g., C. difficile, MRSA, and or CRE. Point 8. Incorporate monitoring of antibiotic use, including the frequency of monitoring/review. Monitor/review response to antibiotics and laboratory results, when available, to determine if the antibiotic is still indicated or adjustments should be made, e.g., antibiotic timeout when the resident is new to the facility, when a prior resident returns or is transferred from a hospital or other facility. 9. During each monthly medication regimen review, when the resident has been prescribed or is taking an antibiotic, or any antibiotic regimen review as requested by the QAA committee. Facilities should provide feedback, e.g., verbal, written note in record to prescribing practitioners regarding antibiotic resistance data, their antibiotic use, and their compliance with facility antibiotic use protocols to improve prescribing practices and resident outcomes. 10. Feedback on prescribing practices and compliance with facility antibiotic use protocols may include information from medical record reviews for new antibiotic starts to determine whether the resident had signs or symptoms of an infection, laboratory tests ordered and the results, order documentation including the indication for use, i.e., whether or not an infection or communicable disease has been documented, dosage and duration, and clinical justification for the use of an antibiotic beyond the initial duration, ordered such as a review of laboratory reports/cultures in order to determine if the antibiotic remains indicated or if adjustments to therapy should be made, e.g., more narrow-spectrum antibiotic. Assess residents for any infection using standardized tools and criteria. 11 e.g. SBAR tool for urinary tract infection UTI assessment. 12. Lobe minimum criteria for initiation of antibiotics. 13. Include the mode, e.g., verbal, written, online, and frequency as determined by the facility of education for prescribing practitioners and nursing staff on antibiotic use stewardship and the facility's antibiotic use protocols. Note: prescribing practitioners can include attending physicians and non-physician practitioners, NPP, i.e., nurse practitioners, clinical nurse specialists, and physician assistants, and require antibiotic orders to include the indication, dose, and duration. The Antibiotic Stewardship Program in relation to pharmacy services. The assessment, monitoring, and communication of antibiotic use shall occur by a licensed pharmacist in accordance with Section 483.45c, F880 Drug Regimen Review. A pharmacist must perform a medication regimen review MRR at least monthly, including review of the medical record and identify any irregularities, including unnecessary drugs. Investigative procedures. Use the infection prevention, control, and immunizations facility task, along with the above interpretive guidance, when determining if the facility meets the requirements for, or when investigating concerns related to, the Antibiotic Stewardship Program. Determine whether the facility's Antibiotic Stewardship Program includes antibiotic use protocols addressing antibiotic prescribing practices, i.e., documentation of the indication, dose, and duration of the antibiotic, review of laboratory reports to determine if the antibiotic is indicated or needs to be adjusted. An infection assessment tool or management algorithm is used when prescribing, and a system to monitor antibiotic use, i.e., antibiotic use reports, antibiotic resistance reports. If there are concerns with the ASP, surveyors must include at least one resident on an antibiotic in the resident sample to assess whether the resident is being prescribed an antibiotic unnecessarily and whether there were any negative outcomes, such as an adverse drug event. Instances of prescribing antibiotics unnecessarily should be cited at Section 483.45d, F857. These findings may support citing Section 483.80a3, F881, as well, in which case the surveyor must also show that the facility does not have or is not implementing an ASP. It may also be necessary to interview the appropriate person, e.g., Director of Nursing, Medical Director, Consulting Pharmacist, Administrator, or Infection Preventionist to verify how antibiotic use is monitored in the facility and confirm with findings from review of the Antibiotic Stewardship Program or resident records. Furthermore, review records including evidence of actions taken by the QAA committee related to antibiotic Use and stewardship. Potential tags for additional investigation. F856 for concerns related to the failure of the pharmacist to review and report any unnecessary antibiotic irregularity. F857 for concerns related to unnecessary antibiotic use, and F852 for concerns related to the right to be fully informed in advance about care and treatment. Key elements of noncompliance. To cite deficient practice at F881, the surveyor's investigation will generally show that the facility failed to do any one or more of the following: develop and implement antibiotic use protocols to address the treatment of infections by ensuring that residents who require antibiotics are prescribed the appropriate antibiotics, or develop and implement antibiotic use protocols that address unnecessary or inappropriate antibiotic use, thereby reducing the risk of adverse events, including the development of antibiotic-resistant organisms, or develop, promote, and implement a facility-wide system to monitor the use of antibiotics. Deficiency categorization. An example of Level 4, immediate jeopardy to resident health and safety, includes, but is not limited to, the facility failed to develop and implement an antibiotic use protocol which included reporting results of laboratory data to the ordering practitioner. Medical record review indicated the prescribing practitioner had ordered a culture and sensitivity for a resident and prescribed an antibiotic for treatment of pneumonia. Prior to receipt of the results of the lab test, the facility received the results of the lab test, which indicated that the bacteria was resistant to the antibiotic prescribed. However, they did not provide this information to the practitioner. As a result, the antibiotic was not adjusted accordingly, and the resident was hospitalized for complications related to the pneumonia. An example of Level 3, actual harm that is not immediate jeopardy, includes, but is not limited to, the facility did not develop a program for antibiotic stewardship and did not develop or implement a system to monitor antibiotic use based on record review. One resident was currently being treated with antibiotics without an appropriate indication for use. The resident had an indwelling urinary catheter and was asymptomatic for an UTI. There was no established criteria for use in the facility for when to treat a catheter-associated urinary tract infection. As a result of the antibiotic therapy, the resident developed nausea and diarrhea that caused avoidable dehydration and prevented the resident from participating in activities and appropriate sleep. The medical record revealed that the antibiotic was stopped and the resident did not have any further adverse effects. The resident was treated via oral rehydration, but did not require hospitalization and fully recovered. An example of Level 2, no actual harm with potential for more than minimal harm. That is not immediate jeopardy, includes, but is not limited to, the facility failed to implement its protocol for antibiotic use and failed to monitor actual antibiotic use. Record review indicated that the facility developed a protocol which indicated residents with MDRO are not to be treated with antibiotics for colonization. However, record review revealed one resident colonized with an MDRO receiving an antibiotic to eliminate colonization. As a result, the potential exists for the resident to develop an adverse drug event, antibiotic resistance, and or CDI. An example of Level 1, no actual harm with potential for minimal harm, includes, but is not limited to, the facility failed to implement their protocol to monitor the rate of antibiotic uses. On review, the monitoring was not completed for 6 weeks. There were no findings of increased MDRO or CDI in the facility. 1 Centers for Disease Control and Prevention. Core elements of hospital antibiotic stewardship programs. www.cdc.gov. Accessed on February 27, 2021 from https://www.cdc.gov/getsmart/healthcare/implementation/core elements HTML. 2 Centers for Disease Control and Prevention. The core elements of antibiotic stewardship for nursing. Homes, www.cdc.gov. Accessed on February 27, 2021 from https://www.cdc.gov/longtermcare/prevention/antibiotic stewardship HTML. 3 Centers for Disease Control and Prevention. Antibiotic resistance threats in the United States, 2013. www.cdc.gov. Accessed on February 27, 2021 from http://www.cdc.gov/drug resistance/threat report. 2013/PDF/rthreats, 2013 to 508, PDF. 4 Spellberg B., Bartlett J.G., and Gilbert D.N., January 24, 2013. The Future of Antibiotics and Resistance. The New England Journal of Medicine, 368, 299 to 302. 5 The White House, 2014. National Strategy for Combating Antibiotic-Resistant Bacteria. Accessed on February 27, 2021 from https://obama.whitehouse.archives.gov/sites/default/files/docs/carb National Strategy PDF. 6C and Note 2. 7C and Note 2. 8C and Note 2. 9C and Note 2. 10C and Note 2. 11C and Note 2. 12 Agency for Healthcare Research and Quality. Toolkit 3. Minimum Criteria for Common Infections. Accessed on February 27, 2021 from http://www.gov/nhguide/toolkits/determine whether to treat/toolkit 3 Minimum Criteria HTML. 13 Loeb M., Brazil K., Lofeld L., Magir A., Simmer A., Stevenson K., Zoutman D., Walter S.D. 2005. Effect of a multifaceted intervention on number of antimicrobial prescriptions for suspected urinary tract infections in residents of nursing homes. Cluster randomized controlled trial. BMJ 331. 669. Accessed on February 27, 2021 from http://www.bmj/early/2004/12/31/bmj.3.86343.55. Full PDF. Tag F882. Section 483.8. 0B Infection Preventionist. The facility must designate one or more individual S as the infection preventionist S, IPS, who are responsible for the facility's IP. The IP must. Section 483.8. 0B1 have primary professional training in nursing, medical technology, microbiology, epidemiology, or other related field. Section 483.8. 0B2 be qualified by education, training, experience, or certification. Section 483.8. 0B3 work at least part-time at the facility, and Section 483.8. 0B4 have completed specialized training in infection prevention and control. Intent Section 483.8. 0B. The intent of this regulation is to ensure that the facility designates a qualified individual S on-site who is responsible for implementing programs and activities to prevent and control infections. Guidance. Responsibility for the infection prevention and control program, including the antibiotic stewardship program. The facility must designate one or more individuals as the infection preventionist IP who is responsible for assessing, developing, implementing, monitoring, and managing the IPP. The IPP includes content required in Section 483.80A14, F880, Infection Prevention and Control, and at F881, Antibiotic Stewardship Program ASP. While the IP is responsible for the IPP, other staff play important roles in infection prevention and control as well as antibiotic stewardship. For example, staff must appropriately implement standard precautions such as hand hygiene and transmission-based precautions. Furthermore, ASP development should include leadership support and accountability via the participation of the medical director, consulting pharmacist, nursing and administrative leadership, and therefore, the IP should utilize and work collaboratively with these team members to also implement the ASP. While an ASP is a team effort, the IP is responsible for ensuring the program meets the requirements for ASPs at Section 483.80A3, F881. The IP should review and approve infection prevention and control training topics and content, as well as ensure facility staff are trained on the IPP. For further information, see Section 483.95E, F945, Infection Control Training. However, the IP is not required to perform the IPP training, since some facilities may have designated staff development personnel. Primary professional training. The IP must be professionally trained in nursing, medical technology, microbiology, epidemiology, or other related field. A professionally trained nurse must have earned a certificate/diploma or degree in nursing. A professionally trained medical technologist, also known as clinical laboratory scientist, must have earned at least an associate's degree in medical technology or clinical laboratory science. A professionally trained microbiologist must have earned at least a bachelor's degree in microbiology. A professionally trained epidemiologist must have earned at least a bachelor's degree in epidemiology. Examples of other related fields of training that are appropriate for the role of an IP include physicians, pharmacists, and physician's assistants. Qualifications. The IP must be qualified by education, training, experience, or certification. The IP must have the knowledge to perform the role. The IP should remain current with infection prevention and control issues, and be aware of national organizations' guidelines as well as those from national/state/local public health authorities, e.g., emerging pathogens. The facility should ensure the individual selected, as the IP has the background and ability to fully carry out the requirements of the IP based on the needs of the resident population, such as interpreting clinical and laboratory data. Examples of experience in infection prevention and control may include, but are not limited to, identification of infectious disease processes, surveillance and epidemiologic investigation, and preventing and controlling the transmission of infectious agents. An example of certification is the certification in infection prevention and control (SIC), which is conducted by the Certification Board of Infection Control and Epidemiology, Inc., CBIC, and accredited by the National Commission for Certifying Agencies, NCCA. IP hours of work. Designated IP hours per week can vary based on the facility and its resident population. Therefore, the amount of time required to fulfill the role must be at least part-time and should be determined by the facility assessment, conducted according to Section 483.71, to determine the resources it needs for its IPP, and ensure that those resources are provided for the IPP too. be effective. Based upon the assessment, facilities should determine if the individual functioning as the IP should be dedicated solely to the IP. A facility should consider resident census as well as resident characteristics, types of units such as respiratory care units, memory care, skilled nursing, and the complexity of the healthcare services it offers, as well as outbreaks and seasonality of infections, such as influenza, in determining the amount of IP hours needed. The IP must have the time necessary to properly assess, develop, implement, monitor, and manage the IP for the facility, address training requirements, and participate in required committees, such as QAA. The IP must physically work on-site in the facility. She cannot be an off-site consultant or perform the IP work at a separate location, such as a corporate office or affiliated short-term acute care facility. Specialized training in infection prevention and control. Infection prevention and control IP training must be sufficient to perform the role of the IP. Specialized training in IPC may include care for residents with invasive medical devices, resident care equipment, e.g., ventilators, and treatment such as dialysis, as well as high acuity conditions. If a facility's resident population changes, the IP should reevaluate his or her knowledge and skills, and may need to obtain additional training for the change in the facility's scope of care. An IP must have obtained specialized IPC training beyond initial professional training or education prior to assuming the role. Training can occur through more than one course, but the IP must provide evidence of training through a certificate tests of completion or equivalent documentation. CMS recommends specialized training include the following topics: infection prevention and control program overview, the infection preventionist's role, infection surveillance, outbreaks, principles of standard precautions, e.g., content on hand hygiene, personal protective equipment, injection safety, respiratory hygiene and cough etiquette, environmental cleaning and disinfection, and reprocessing reusable resident care equipment, principles of transmission-based precautions, resident care activities, e.g., use and care of indwelling urinary and central venous catheters, wound management and point-of-care blood testing, water management, linen management, preventing respiratory infections, e.g., influenza, pneumonia, tuberculosis prevention, occupational health considerations, e.g., employee vaccinations, exposure control, plan and work exclusions, quality assurance and performance improvement, antibiotic stewardship, and care transitions. A free online training is available and was developed by a collaboration between CMS and the Centers for Disease Control and Prevention, CDC. The Nursing Home Infection Preventionist Training Course is located on CDC's Train website. https://www.train.org/cdctrains/training plan/3814. Other trainings may be available from entities such as associations, state public health, and universities. Investigative procedures. Use the infection prevention, control, and immunizations facility task, along with the above interpretive guidance, when determining if the facility meets the requirements for, or when investigating concerns related to, compliance with the infection preventionist requirement at Section 483.80b14 IE. Role, qualifications, training, and allowed time for the position. Instances of the facility not implementing transmission-based precautions when indicated should be cited at F880. These findings may support citing F882 as well, in which case the surveyor must also show that the facility did not ensure requirements at Section 483.8 F880B were met. For example, F882 should be cited if the IP was not available to assist staff on multiple occasions with their questions on when transmission-based precautions should be initiated for a resident due to lack of sufficient time to perform the IP role, and this led to non-compliance. With F880, the facility may be cited at an infection control tag such as F880, but not at F882. 4. Example, F882 should not be cited if all requirements at Section 483.80b are met, but a staff member did not clean and disinfect reusable resident care equipment, e.g., blood pressure cuff, thermometer after use on a resident on transmission-based precautions, and it was then used on the next resident, despite proper policies and procedures, staff training and process. Surveillance of staff practices, addressing this concern. Conversely, the facility can be cited at F882, although not at F880, F881, or F945 in cases where a surveyor's investigation began with an infection control concern, leading to a review of the IP, but in the end did not result in evidence of noncompliance at another infection control tag, e.g., F880, F881, or F945. For example, during the investigation, the surveyor found through record review that the IP did not have specialized training. Surveyors should utilize the quality assessment and assurance CA and quality assurance and performance improvement CAPI plan review facility task to determine compliance with Section 483.80c, IP participation on QAA committee. Key elements of noncompliance. To cite deficient practice at F882, the surveyor's investigation will generally show that the facility failed to ensure that the IP was overseen by a qualified individual who meets the requirement for professional training or adequately assesses, develops, implements, monitors, and manages the IP, or has the appropriate knowledge and skills to care for the IPC needs of the facility's resident population and to be responsible for the IP, or has time to perform IP responsibilities, or performs IP duties in the facility, or completed specialized training in IPC. Deficiency categorization. An example of Level 4, immediate jeopardy to resident health and safety includes, but is not limited to, the facility failed to ensure the IP was qualified by education, training, experience, or certification to identify a gastrointestinal outbreak in the facility and implement appropriate control measures. Surveyors identified that the IP did not ensure that appropriate control measures, e.g., transmission-based precautions, environmental cleaning, and disinfection and reporting to public health occurred. As a result, several residents became seriously ill with diarrheal illnesses resulting in dehydration. An example of Level 3, actual harm that is not immediate jeopardy includes, but is not limited to, the facility failed to ensure the IP implemented the IP appropriately for a case of pediculosis, i.e., head lice, and the resident's roommate also became infested. Per the IP and CDC recommendations, the resident should have been placed on contact precautions until 24 hours after the application of an effective treatment. The IP participated in an interview and confirmed that she was aware of the diagnosis, but did not ensure contact precautions were initiated. An example of Level 2, no actual harm with potential for more than minimal harm. That is not immediate jeopardy includes, but is not limited to, the facility failed to ensure the IP was performing the duties of the position and was qualified to perform the role. The IP did not ensure the facility had an antibiotic stewardship program. Based on record review, the facility could not provide documentation for an antibiotic stewardship program. During the interview, the IP demonstrated a lack of understanding of an effective program and how to implement an antibiotic stewardship program. Additionally, during the interview, the IP confirmed that she did not have training in antibiotic stewardship. An example of Level 1, no actual harm with potential for minimal harm includes, but is not limited to, the facility failed to ensure the IP had appropriate time to perform IP responsibilities. Record review and interview S revealed that the IP failed to ensure that the IP was reviewed annually. The IP verified that she did not have enough time on site to update the IP by its annual deadline, and 2 months had passed since an update was required. There were no infection control findings outside of annual review and documentation. Potential tags for additional investigation. F838 for concerns related to the facility assessment. F867 for concerns related to the QAA committee's responsibility to identify or correct quality deficiencies, which may include systemic infection control concerns. F868 for concerns related to the QAA committee to include the IP's participation. F880 for concerns related to infection prevention and control. F881 for concerns related to the antibiotic stewardship program, and F945 for concerns related to staff training on the standards, policies, and procedures of the infection prevention and control program. Tag F883. Section 483.8, 0D influenza and pneumococcal immunizations. Section 483.8, 0D1 influenza. The facility must develop policies and procedures to ensure that before offering the influenza immunization, each resident or the resident's representative receives education regarding the benefits and potential side effects of the immunization. Roman 2. Each resident is offered an influenza immunization, October 1 through March 31 annually, unless the immunization is medically contraindicated or the resident has already been immunized during this time period. Roman 3. The resident or the resident's representative has the opportunity to refuse immunization, and Roman 4. The resident's medical record includes documentation that indicates, at a minimum, the following: A. That the resident or resident's representative was provided education regarding the benefits and potential side effects of influenza immunization, and B. That the resident either received the influenza immunization or did not receive the influenza immunization due to medical contraindications or refusal. Section 483.8, 0D2 pneumococcal disease. The facility must develop policies and procedures to ensure that before offering the pneumococcal immunization, each resident or the resident's representative receives education regarding the benefits and potential side effects of the immunization. Roman 2. Each resident is offered a pneumococcal immunization, unless the immunization is medically contraindicated or the resident has already been immunized. Roman 3. The resident or the resident's representative has the opportunity to refuse immunization, and Roman 4. The resident's medical record includes documentation that indicates, at a minimum, the following: A. That the resident or resident's representative was provided education regarding the benefits and potential side effects of pneumococcal immunization, and B. That the resident either received the pneumococcal immunization or did not receive the pneumococcal immunization due to medical contraindication or refusal. Intent. The intent of this regulation is to minimize the risk of residents acquiring, transmitting, or experiencing complications from influenza and pneumococcal disease by ensuring that each resident is informed about the benefits and risks of immunizations, and has the opportunity to receive the influenza and pneumococcal vaccines, unless medically contraindicated, refused, or was already immunized. Ensure documentation in the resident's medical record of the information/education provided regarding the benefits and risks of immunization, and the administration or the refusal of or medical contraindications to the vaccines. Definitions. The Advisory Committee on Immunization Practices, a SIP, refers to a group of medical and public health experts that develops recommendations on how to use vaccines to control diseases in the United States. A SIP's recommendations stand as public health advice that will lead to a reduction in the incidence of vaccine-preventable diseases and an increase in the safe use of vaccines and related biological products. See http://www.cdc.gov/vaccines/asip/index.html for further information. Medical contraindication refers to a condition or risk that precludes the administration of a treatment or intervention because of the substantial probability that harm to the individual may occur. Precaution refers to a condition in a potential recipient that might increase the risk for a serious adverse reaction or that might compromise the vaccines. Induction of immunity, for example, as a result of the resident's condition. Complications could result, or a person might experience a more severe reaction to the vaccine than would have otherwise been expected. However, the risk for this happening is less than expected with medical contraindications. Guidance. Overview. Receipt of vaccinations is essential to the health and well-being of long-term care residents. Establishing an immunization program against influenza and pneumococcal disease facilitates achievement of this objective. Influenza outbreaks place both the residents and staff at risk of infection. In addition, pneumococcal disease carries serious morbidity and mortality due to its major clinical syndromes of pneumonia, bacteremia, and meningitis. People 65 years or older are 2 to 3 times more likely than the younger population to get pneumococcal infections. An effective immunization program involves collaborating with the medical director to develop resident care policies for immunizations that reflect current standards of practice and that include physician-approved policies for orders of influenza and pneumococcal vaccines. Administration must be based on an assessment of each resident for possible medical contraindications. See 483.30b3, F880 for physician orders for vaccinations. Review of the resident's record of vaccination and immunization status, including assessment for potential medical contraindications. How pertinent information and education will be provided to residents or their representatives. The facility may wish to use educational resources such as those provided by the U.S. Centers for Disease Control and Prevention, CDC-1, and the vaccination schedule, including mechanisms for recording and monitoring for administration of both influenza and pneumococcal vaccines in accordance with national recommendations. 2. Note: review facility policies regarding the provision of vaccines in order to determine if the policies reflect current standards of practice. Refer to Section 483.2, 1b3i. The services provided or arranged by the facility must meet professional standards of quality F658, Also, refer to F880 for concerns with infection prevention and control, provision of immunizations. In order for a resident to exercise his or her right to make informed choices, it is important for the facility to provide the resident or resident representative with education regarding the benefits and potential side effects of immunizations. Facilities are required to document the provision of this education and the administration, refusal of the immunization, or the medical contraindication of the immunization. There may be clinical indications or other reasons that a resident may not have received immunizations. The resident's record should show vaccination administration unless it contains documentation as to why the vaccine was not administered, including but not limited to the following. A decision may have been made to delay vaccination for a resident because a precaution is present. According to the CDC, in general, vaccinations should be deferred when a precaution is present. However, a vaccination might be indicated in the presence of a precaution because the benefit of protection from the vaccine outweighs the risk for an adverse reaction. The presence of a moderate or severe acute illness with or without a fever is a precaution to administration of all vaccines. Point 3. The benefits and risks of receiving the vaccine should be discussed with the resident or resident representative if a resident has a precaution to a vaccine. The vaccine can be administered if the benefit of the vaccine outweighs the risk. The resident or resident representative provides consent, and the resident's physician approves. Refer to Section 483.30, Physician Services, for further information on physician supervision. A resident may be in the end stages of a terminal illness and receiving care that is limited to comfort or palliative measures only, and although eligible, the resident or representative has refused the vaccination. A resident may have a medical contraindication to receiving an influenza or pneumococcal vaccine, such as severe allergic reaction to a vaccine component or following prior dose of vaccine. The resident or representative refused the vaccine, or the resident has already been immunized. Note: additional information related to current vaccine recommendations, including scheduling and contraindications, may be found in CDC's Epidemiology and Prevention of Vaccine-Preventable Diseases, otherwise known as the Pink Book, at http://www.cdc.gov/vaccines/asip/index.html or https://www.cdc.gov/vaccines/pubs/pinkbook/chapters.html. Note: references to non-CMS sources are provided as a service and do not constitute or imply endorsement of these organizations or their programs by CMS or the U.S. Department of Health and Human Services, HHS. CMS is not responsible for the content of pages found at these sites. URL addresses and reference documents were current as of the date of this publication. Guidelines change, and facilities are responsible for following the most current standards. Note: a nursing home may encounter residents who do not have adequate documentation of vaccinations, with the exception of influenza vaccine and pneumococcal polysaccharide vaccine, PPSV. Providers should only accept written, dated records as evidence of vaccination. Self-reported doses of influenza vaccine and PPSV are acceptable. A resident representative can report on behalf of the resident if he/she is unable to self-report and the representative has knowledge of the resident's medical care. State laws may have more stringent requirements related to documentation. Influenza immunization. The influenza vaccine is given seasonally. The CDC indicates that administering the vaccine when it becomes available each season, rather than date-specific, i.e., October 1, is most effective. Facilities should administer the influenza vaccine when it becomes available to the facility. Residents admitted late in the influenza season, typically February or March, should be offered the influenza vaccine, as late-season outbreaks do occur. If a resident was admitted outside the influenza season, the facility is not expected to offer the influenza vaccine to the resident, but it may, at its discretion. Note, flu seasons are unpredictable in a number of ways. They can vary in different parts of the country and from season to season. While flu spreads every year, the timing, severity, and length of the season varies from one year to another. If there is a national shortage of influenza vaccine or other issue with availability leading to an inability to implement the influenza vaccine program, ask the facility to demonstrate that the vaccine has been ordered and the facility received either the vaccine or a confirmation of the order, indicating that the vaccine has been shipped or that the product is not available but will be shipped when the supply is available. Plans are developed on how and when the vaccines are to be administered. Residents have been screened to determine how many and which residents are eligible and wish to receive the vaccine, and education regarding immunizations has been implemented. Pneumococcal immunizations. The regulation requires that each resident is offered pneumococcal immunization unless the immunization is medically contraindicated or the resident has already been immunized. There should be documentation in the medical record if there is reason to believe that pneumococcal vaccine S was given previously, but the date cannot be verified, and this had an impact upon the decision regarding administration of the vaccine S. Facilities should follow the CDC and ACIP recommendations for vaccines. For up-to-date information on indications and timing of pneumococcal vaccines, please refer to CDC's ACIP vaccine recommendations and guidelines website located at http://www.cdc.gov/vaccines/hcp/aciprex/index.html https://www.cdc.gov/vaccines/vpd/pneumo/downloads/pneumo vaccine timing PDF and https://www.cdc.gov/vaccines/schedules/hcp/index.html. Investigative procedures. Use the infection prevention, control and immunizations facility task, along with the above interpretive guidance, when determining if the facility meets requirements for, or when investigating concerns related to, influenza and pneumococcal immunizations. Sampling procedure. Select 5 residents in the sample to review for the provision of influenza and pneumococcal immunizations. Record review. Review sampled residents' records for education on and provision, refusal, or documentation of medical contraindications for influenza and pneumococcal immunizations. As necessary, determine if the facility developed influenza and pneumococcal vaccine policies and procedures. Key elements of noncompliance. To cite deficient practice at F883, the surveyor's investigation will generally show that the facility failed to do any one or more of the following: develop, maintain, or follow policies and procedures for immunization of residents against influenza and pneumococcal disease in accordance with national standards of practice, or vaccinate an eligible resident with the influenza and/or the pneumococcal vaccine S, unless the resident had previously received the vaccine, refused, or had a medical contraindication present, or allow a resident or a resident's representative to refuse either the influenza and slash or the pneumococcal vaccines, or provide and slash or document the provision of pertinent information regarding the immunizations to the resident or the resident's representative, such as the benefits and potential side effects of the influenza, and, as applicable, the pneumococcal immunizations, or document that the resident either received the pneumococcal and influenza vaccines or did not receive the vaccines due to medical contraindications, previous vaccination or refusal, deficiency categorization. Examples of Level 4, immediate jeopardy to resident health and safety include, but are not limited to, the facility failed to ensure that medical contraindications were identified for the influenza or pneumococcal vaccine and administered the vaccine to a resident with identified allergies/contraindications. As a result, the resident experienced a life-threatening reaction of anaphylactic shock, requiring immediate treatment and admission to the hospital. The facility failed to ensure that eligible residents received the influenza vaccine because it did not have a program for vaccinating residents. As a result, several unvaccinated residents in one unit developed influenza with elevated temperatures, coughing, labored breathing, and required hospitalization for respiratory compromise and dehydration. Examples of Level 3, actual harm that is not immediate jeopardy includes, but are not limited to, a resident who was not eligible to receive the influenza vaccine due to medical contraindications, received the vaccine, and experienced a reaction that was not serious or life-threatening, i.e., hives and dizziness. The reaction resulted in fear and anxiety that was not to the level of panic and immobilization, but required treatment. The facility failed to administer the influenza vaccine for several weeks, despite its availability. The facility failed to offer influenza immunization to 3 residents who were eligible to receive the vaccine. Record review and staff interview revealed that the 3 residents had been admitted in the past 2 months, but their names were not included in the facility's monitoring log for residents who had not received the vaccine and when they had last received one. During interviews, 2 of the 3 residents stated that they had not taken a flu shot in over a year, and one stated that he had never taken a flu shot, but all 3 stated they would have taken one if offered. Based on record review, 2 of the 3 residents were diagnosed with influenza, with symptoms of fever, chills, body aches, and had received treatment with an antiviral in the facility. The 2 residents were unable to participate in activities or leave their rooms due to the acute illness. Record review corroborated the interview information, and when interviewed, staff stated they had overlooked the 3 residents. Examples of Level 2, no actual harm, with potential for more than minimal harm. That is not immediate jeopardy include, but are not limited to, an eligible resident did not receive the vaccine, but did not develop symptoms of influenza. An eligible resident received 2 doses of the same pneumococcal vaccine. The facility could have determined the resident already received the vaccine had it documented in the medical record when it was previously given by the facility. The resident did not experience any untoward reactions from the second immunization. The staff did not assess a resident for medical contraindications prior to providing the vaccines, but there were no reactions to the vaccines. An example of Level 1, no actual harm with potential for minimal harm includes, but is not limited to, the facility failed to document that the resident was provided education on the influenza vaccine prior to administration. When interviewed, the resident stated he had received a copy of the information on influenza risks and benefits and provided the copy to the surveyor. However, the medical record did not reflect receipt of the information. 1 Centers for Disease Control and Prevention. Vaccine Information Statements. www.cdc.gov. Accessed. On February 27, 2021, from https://www.cdc.gov/vaccines/hcp/vis/index.html. 2 Kroger at Dutchen J.V. Zequez M. General Best Practice Guidelines for Immunization. Best Practices. Guidance of the Advisory Committee on Immunization Practices (ACIP). www.cdc.gov. Accessed on February 27, 2021, from https://www.cdc.gov/vaccines/hcp/aciprex/generalrex/index.html. 3CN Note 2. This concludes the reading of Appendix PP. Regulation Section 483.80, tags F880 through F883.